All right. Very good morning, everybody. I'm actually letting that sink in. It's too much to take, but it is, fulfills my eyes like to be here, to be able to do this today. It's truly an honor to welcome all of you here, patients, caregivers, survivors, families, researchers, physicians, advocates, industry partners. This room represents something very powerful, right? A community. The Cholangiocarcinoma Foundation is really near and dear to my heart. I first came across the foundation when I was working in West Virginia, and at that time, I was still deepening my understanding of biliary tract cancers, the bile duct cancers. But what struck me immediately was not just the science, it was the advocacy, the breadth of support, the education, the relentless effort to connect patients who often feel alone in the process. Many people do not understand fully what this foundation does behind the scenes, but I saw it firsthand and I'm fortunate. Since then, I've attended their annual symposium every year. And the reason why is because you sit in a conference annual meeting in Utah, where there are patients and caregivers together with everybody who I listed before, and there is no hierarchy in the room. There's just one shared purpose, like fight the cancer, fight cholangiocarcinoma. And what better place could there be to truly understand what patients need at the ground level, right? That is where unmet need becomes visible. And that is where research questions are born. And that is where collaborations happen. And that is how we go back to our labs, to our clinics and institutions and come back stronger the next year. I remember giving a talk at one of the symposiums a couple of years ago in Utah. And after the talk, I was really humbled and honored. There's a lineup of patients and families with their reports of ctDNA and questions asking me what to do. That really humbled me. And at the same time, also tells me there is that hope. And we, as our providers, as a community, need to make sure that hope and research and continues to move that forward. And to be honest, patients that interact during those meetings are they're the smartest patients I've ever met. They ask thoughtful questions, they ask challenging ones too. And they also ask forward-looking questions, right? And that inspires me and it reminds me again for what we do and why we do. For years, I've been wanting to bring that to Alabama, and I think this is probably 3 years in discussion with Melinda and Stacy. And I can't tell you how grateful and proud I am to see that all of you are here today, just one day after World Cholangiocarcinoma Day. I mean, this could not be any more meaningful time. Today is about education, empowerment, partnership, and it is about hope grounded in science. So we have an excited lineup of speakers and sessions for you, covering treatment advances, personalized medicine, clinical trials, but all of that at the patient level, right? We try to make sure we keep it simple, keep it easy to understand, but at the same time, you ask us tough questions, we try hard to answer them. So without further ado, let's go ahead and get symposium started. So I thank our industry sponsors and also we're supporting the 20th anniversary. And here we go. I mean, having the map of CCF in Birmingham, I think it pleases me, right? I've got some of this from the X. And February is Cholangiocarcinoma Awareness Month. And it was yesterday, with being the World Cholangiocarcinoma Day. And we had our team meet CCF team and so excited to know what CCF offers and CCF to know what our team offers. And then we also had great, evening reception last night. It was a at a very good place, Uptown Cantina. Had good time, and we also had a lot of fun and smiles too. So, and we had Dr. Erin come by, our C2 director, and now I'd like to introduce Dr. Anupam Agarwal. We are honored to have him here. He's our Senior Vice President of Medicine and Dean of Pershing School of Medicine at the University of Alabama. He's a nationally recognized physician scientist and a leader in academic medicine. He directs the NIH-funded O'Brien Center for Acute Kidney Injury and has authored more than 200 publications. Dr. Agarwal is also deeply committed to education and mentorship, having trained a lot of future academic leaders. We're grateful to have him with us today.
Thank you. Good morning, everyone. Really delighted to be here today. I appreciate the leadership of Dr. Midhan Malla and his team for putting this meeting together. I have a personal story about Dr. Malla. He took care of one of my relatives whose parent was from Crimea and could only go to Russia for treatment, but because of the war, nothing could be done. And ended up coming here, and within 24 hours, he had started a treatment plan for this gentleman. He stayed with us for about 6 months, and he went home cancer-free. And it would not have happened without Dr. Malla. And he, most importantly, besides the knowledge, his compassion, his empathy was really second to none. So, Midhan, thank you. Good morning, everyone. Really appreciate the kind introduction. Really pleasure to welcome you all to the Birmingham Regional Cholangiocarcinoma Symposium. I'm really grateful that you all have joined us today. I want to extend a special welcome to patients and caregivers that are here with us. Your strength, your experiences, and trust mean a great deal to us here within the Heersing School of Medicine and broadly UAB Medicine. You remind us why this work really matters. Cholangiocarcinoma is a complex and challenging disease. I don't need to tell you that. And we recognize the uncertainty that this brings for families. That's why this gathering is so important. It gives us the chance to learn from one another and focus together on meaningful progress. Today brings together, as Dr. Malla said, clinicians, researchers, advocates, and more importantly, the individuals and families that are directly impacted by this disease. Each of you plays a critical role in helping us deepen our understanding and moving forward for better diagnostics, better therapies, and better outcomes. Your voices will help shape the care we provide and the research that we pursue. At the Heersing School of Medicine and also our O'Neill Comprehensive Cancer Center, we remain deeply committed to improving care for patients with cholangiocarcinoma. My hope is that today will provide you with clarity, with useful information, and a sense of community. I love the tagline that you have, strength in community, hope in research. You're not navigating this alone, and we're honored to walk alongside with you. I want to thank the Cholangiocarcinoma Foundation for its partnership and for bringing this important program to our region. And thank you all for being here and for the resilience and courage you bring to this work. I hope the conversations ahead are both informative and encouraging as we continue striving together for progress, compassion, and hope. Thank you all, everyone, for being here again.
All right. I think everybody has their agenda, and can't wait to start any longer. But before that, a few housekeeping notes, right? I mean, I guess everybody know where the restrooms are. Very important, like very close by to us. So it's a very good building, actually. I've never been here before. I mean, you can see what's happening outside, and thankfully the weather is good today. And hope we really don't need to use emergency exits today, but know where they are too. Cell phones, please silence them. We really appreciate it. Pagers, if you can silence them or vibrate, much appreciated. I hope you already know the Wi-Fi name and the password. The sessions are recorded. We hope to also have them virtually as well after maybe a few days. Please come ask questions, right? They matter. No question is too small. And if you're wondering about it, others are probably too. So please do ask questions. We try to do our best to stay on schedule and while at the same time to cover important topics and meaningful discussion. And more importantly, as I can't say it enough, education, empowerment, community is what the goal is today. So this really is another honoring moment for me is to invite Stacy Lindsay on here and also to be able to lead the foundation and start with the foundation when I watched her video on X yesterday, like back in 2007. how she had a loss in the family, and back when there was no recognition for cholangiocarcinoma and no research, like, not a biomarker that we know of, we're just using chemotherapy. What she has done from there until fast forward to 2026 is phenomenal. So we really truly honored to have you here, Stacy. After losing, her brother Mark to cholangiocarcinoma, she turned her advocacy and determination into a mission to connect patients, researchers, healthcare professionals. Since the foundation's beginning, Stacy has served as a guiding leader and a dedicated board member, helping build a powerful community of hope and support. During our annual symposiums, it's really hard to even get a minute to talk to Stacy. That's how in the middle and center of that the event she's in, and it is taking on to the next level. So I really would like to welcome her to speak a few words.
Good morning. I'm Stacy Lindsay. I'm the CEO of the Cholangiocarcinoma Foundation, and we just want to welcome you and thank you to Dr. Mala and Wall. Thank you for hosting us here. Thank you for your team for being here and for providing this beautiful place for us to meet. Just going to tell you a little bit about the foundation and then we'll get started. Want to thank our sponsors again. Dr. Mala already did that, but we can't do this work without our wonderful sponsors. And Natera is out there. They're welcoming you and have information for you. If there's anything you need, please visit their booth. Also, this is our 20th anniversary. And so that's an exciting milestone for us. A lot has happened in the last 20 years, but we want to thank our anniversary sponsors, Insight and Taiho. I also want to introduce you to our team that are here on the ground. This is Melinda Bikini. Melinda, we want to stand up. Melinda is a 16-year stage 4 cholangiocarcinoma survivor. This is Karen. Karen is our director of communications. And so all of the great content you see on social media, that's directly from Karen's team. She also is a resident here. So she's your contact here. I want to introduce Emma. I don't know if Emma's out on the registration booth. She's the one running around doing all the technical things. And then Elizabeth is out there as well. So if you have any questions, please connect with, oh, here they come.
You gotta give a speech.
This is Emma. We are a tall group. I'll just say that. Our mission is to find a cure and improve the quality of life for cholangiocarcinoma patients. And it started with our family's personal story. This is my brother, Mark. He was 38 years old. He was a lawyer and a serial entrepreneur. When he was diagnosed, he'd just run a marathon and his wife was just 2 months from having their 4th child. So this was a desperate situation for our family. And unfortunately, we could not find any information. There was nothing on the internet. There were no organizations. None of the institutions had any information on the web about cholangiocarcinoma. So we were distressed. And our personal story and our passion to solve a problem, our family problem, and to help Mark turned into something bigger because Mark only lived 15 months. And so he asked us to do something about that. And while our personal story and our passion are important, and so are your individual stories and your passion, you really cannot do anything unless you also have the experts join you. And so this is our nursing advisory board. This is our ICRN members, our research network members, our SMAB, our scientific medical advisory board members. These are the people who 20 years ago, who were young investigators who stepped up to help us do something meaningful. And what has happened now is maybe a little bit unique in a rare cancer space, but when passion meets expertise, an organization gains real power. And that's what happened. The entire community came together. We are the hub, and all of those stakeholders work with us. And that the most meaningful thing that we do all year happens at our annual conference in Salt Lake City. This will be our 13th annual conference there. It's a global opportunity for all of the scientists to come together to collaborate, all of the major institutions and the smaller institutions as well, and then patients from all over the world are there. And you can see what happens when the global community comes together. You can see Mark was diagnosed in late 2005 and 2006, the foundation started. And then you can see we didn't even have our first approval, glasses on, till 2009, which was when John Bridgewater and Dr. Juan Valle did the ABC series. So that we had our first standard of care. It was not a good one, but we had a start. And so, right, we got started there. And then you can see as we start moving and we start getting organized, we're all working together. We just start getting approvals and drugs moving through the pipeline. And that's the important thing here, is that we get better treatment options for patients by all working together. So we have two strategic priorities at the foundation. One is making sure that patients and caregivers have what they need. And the second is making sure we're supporting the research community and our industry partners to get breakthrough treatment options for them. So we're going to focus just a minute on advocacy, and this is Melinda's area, and she can answer any questions for you. But there are several things that we're doing. I'll just take you through a few of the programs. One of the very first things that's very important to us is that the patients get to the right team. Now here at UAB, if you're being seen here, you're at the right team. You've got it has to be a multidisciplinary team. All of the specialists are going to come together. They're going to talk together. They're going to find out what's the right treatment for you. This is a difficult to treat disease, and most of our patients are seen in a community setting. They need to get a second opinion somewhere where they can get all clinical trial options, research options. They can see a multidisciplinary team. So this is really important to us. The second thing is they're getting the right tests and they have options for the right treatments. If you're not being seen at an academic center, you're not going to get access to clinical trials always. And that's really important because you saw that pipeline of all those drugs being approved. Those are patients participating in clinical trials. So really important to get your biomarker testing. And then that gives you access to certain treatments. We do webinars twice a month for patients. These are patient education webinars. We have multiple support groups. We do a lot of social media. We have a free nutrition book. We have a brand new patient book that's coming out, or a patient guide that was written by Dr. Juan Valle. And then the whole team's been working on this. It's been approved by the ICRN. The global community's been looking at it and adding resources as well. We think it's going to be really amazing. So we're excited for our 20th anniversary to have a brand new book. We provide newly diagnosed or newly connected. If they're newly connected to us, we provide a care kit for patients that has all of these free resources in it. It can help you get connected. And what we would ask the physicians, the clinicians, the scientists in the room is to connect your patients to us so that we can help them. And I'll show you a few more ways that we're helping them. We have a program called Cholangio Connect, and this is a mentoring program. In the last several years, we've matched over 1,800 patients with a mentor or caregivers with a mentor. You can see all of those countries. Those are patients that we're mentoring from those countries. It's a significant need across the globe for mentoring. And we have many mentors in this room who are patients themselves, but who are mentoring other patients. So thank you. It's such a amazing thing to do when you are in need yourself. We're so grateful. Just a quick about the care teams. And we have 4 members of our Nashville care team right here in the front. As ladies want to raise your hand. And we have care teams, and this is just groups of patients and caregivers, all local to one area, who want to get together. They're helping educate and support each other. And so there's one in Baltimore, Washington, D.C. area, Chicago, Houston, Nashville, New England, and Seattle. But we're always open. If you feel like you have a group that's in Alabama, and you want to start a little group, then we can help you do that. Another important initiative for us is that there are small cholangiocarcinoma nonprofits or charities popping up all over the world. We are the biggest, but we have really important partners, AMMF in the UK. There's a very strong Canadian group, there's a strong group in India, very strong group in Spain. But then we have tiny little groups that might just be 1 or 2 people who are working on different things. They don't have the resources that we have. So we white label everything that we do. We give that to them so that they can translate it, put it on their website, use it for patients. We share our expertise, and we give them access to the global pharma connections that they need for support. So we're so grateful for these groups. We just realized that you saw back on the Cholangio Connect, all those countries who are reaching out to us, but really the best support that they can get is support within the healthcare system that they're working in. And so we're willing to help anyone, but we realize that. So we really want to help these organizations help the patients wherever they live. The second pillar of our strategic priorities is research. And our last annual conference, we did something unique. We brought the global community together, about 800 scientists, clinicians, academics from everywhere, patients, caregivers, the whole group. And we worked on, it was a year-long effort to work on what are the global research needs. What are the global research needs in surgery, in pathology? There were 10 working groups. We worked this through, and then we had the consensus conference, and we came up with 49 recommendations that were developed. Now, the foundation can't do all 49. We're going to administer some things are already happening, and some things we'll have to fund. And so right now we're in the process of the executive summary has been done. The manuscript from that has been sent for publication, and then additional publications are coming. But that really set the tone for us for the next 3 to 5 years, what we need to do as a global community to what research is priority for us. So we were very excited and grateful for everyone who participated in that. Tell you just a little bit about the ICRN. This is the International Cholangiocarcinoma Research Network. We have about 480 members, 228 institutions in 36 countries. This is how we're getting work done. We're working together across the globe on these important research priorities. Dr. Ben Stanger from the University of Pennsylvania and Dr. Nilo Azad from Johns Hopkins are the chairs of that committee. There's a next generation committee. This is where we're mentoring all the up and coming group. This is really strong mentorship happening there. Lots of opportunities. There's a research committee that does all of our grant approvals. Quite a large international group there as well. There's a data committee. I'll talk with you just a little bit about the data that we're working with. This is publishing and some of the seminal publications that will come out this year. And then a program organizing committee that really help us decide what are the most meaningful meetings that we need to be at for global collaboration. So we have a large research grant mechanism. We do 10 fellowship early career grants per year. We do one career development award. It's a 3-year grant, $100,000 every year. And so every year we do a new one. So there's, 3 consecutively moving through. And then we do an innovation grant. That's a $250,000 per year grant. That's a collaborative institutional grant. And so we're excited to have just awarded our second one. This is the history of our research fellowships. We started in 2015, so about $4 million has gone to that program. And you can see we aren't interested in funding one institution. We're interested in funding the best research. And these fellows have been very successful, and we've had some really exciting things come from this research. So we're so grateful for them. So for the data committee, one of our sources of data is Komodo Health, is a claims data. There are lots of similar ones, but this is some work that we're doing there, that team is doing there, and they've got multiple projects that they're working on. The one that's most important to me is the incidence and evidence or prevalence data that we've been working on with Komodo for several years. That data will be coming out this year. We're very excited about that. Or again, the program organizing committee, the next generation committee, if there's interest there, gosh, there are lots of opportunities for young investigators. And to date, this is the investment that CCF has made doing fundraising. It's $5.2 million invested in patient services. That's advocacy, education support, and almost $10 million in research. And I just wanted to add on to what Dr. Mala said. The conference experience is really where this all comes together, where everyone's at the table. It's a very warm, inviting, hopeful place. And Luke Bolter and Tim Gretton's at the NIH, and Luke Bolter's at Edinburgh, are chairing next year. But I just want to talk just a little bit about this cycle of hope that we see at the conference. It's a unique thing. And even though the patients that are there, this is a very high level scientific conference, but we invite the patients and caregivers to share their stories there. It's a unique opportunity for regulators to hear patient stories, and for scientists who've worked in cholangiocarcinoma their whole life but have never heard a patient story, for them to be inspired by these personal stories that they're hearing, and also for the patients to be inspired by the science and the discussions and the disagreements and the pushback that they're seeing. That's very exciting for them. They don't have to understand the science. They just have to know that the top global leaders are meeting together and trying to solve this problem. And so I hope that you will come. Let me just go back here. There you go, May 1st through the 3rd, 2026. It's always in Salt Lake City. We would love to have you join us. Again, this is just, it's such a wonderful, hopeful place to be where you're gonna see the latest science, the latest clinical trial options. Everyone's there working together. You can talk to all the industry partners who are there, ask them questions. Patients bring all their information to get as much as they can. Just so thankful and grateful to be here and excited to get to know all of you. And I will turn it back to Dr. Muller.
Thank you, Stacy. I think I've seen the slides a couple of times, but no matter how many times I see, it brings tears, it brings joy, it brings a lot of happiness, but at the same time, also reminds that we need a lot more to do, right? I mean, we have a lot more to accomplish, a lot more to do, and we could only do it with team effort. And thanks for leading such a great organization and see how impact it is creating across the globe. So that's phenomenal. All right, now let's go and get started with our first session. Dr. Elisa Knight and Dr. Robbie Cannon, along with me, we are chairing the first session. We plan to start with our first speaker and then have this, 3 talks completed, and then have to have all of the, speakers and the chairs, sit in front of you so we can have a conversation again, question and answers, right? Type of session. So with that, I would like to welcome Dr. Bo Toskich. He is somebody that I also know when I was in West Virginia. He is one of the most knowledgeable IR guys that I have met, and I think that still holds true. Very, very knowledgeable, but at the same time quite humble guy. I mean, he tells you directly what's right, what's the data out there, published quite a bit, continues to do great things. And then the first text that I sent him, hey, can you join us for the symposium? He responds right away. What topic you want me to talk on? And I tell him, like, this is a patient symposium. I would want you to educate us and our patients, like what you do, why you do. And he's like, all right, I have my topic ready. And then a few days later, he's like, can you get me a whiteboard? Rather than just doing the usual slides and such, which I have prepared, but I think I'm going to do a chalk talk. So he came in, he checked on it yesterday. I think we're all good to go. So I'm really looking forward to his chalk talk as well. We're honored to welcome him, and he is an interventional radiologist specialist in interventional oncology with a focus on treating primary and metastatic liver cancers, including biliary tract cancers, widely recognized for advancing innovative liver-directed therapies, including leading international research combining radioembolization with immunotherapy. He collaborates across oncology specialties to provide comprehensive care. So, Dr. Toskich, welcome.
I'm gonna be moving. We're here. If you guys have any trouble hearing me, just let me know. But I want to personally thank the Cholangiocarcinoma Foundation, and I just can't echo enough, Stacy, when you talk about that cycle of inspiration. I've been doing this, we're actually just reminiscing. I started this whole journey for myself in terms of helping treat patients with this diagnosis back in 2007. And I still can't thank you enough for sharing and everything that you've done, because I really feel inspired leaving this room today. So thank you for that. So I'm gonna attempt the screen. How's the glare? Can you guys hear me again? When I was an intern, I actually started off my career in surgery, and interventional oncology, which is what I practice right now, didn't really exist. And one of the things that I noticed was, as an intern in our compatibility clinic, there were so many patients that could not be resected. And it was heartbreaking because they didn't have disease that had moved outside the liver, didn't go to the nose, didn't go anywhere else. It's still the liver, but just found a way to present itself. And even the best surgeons were removing it safely. And we still believe in surgery as the gold standard. And if you can remove it, it's in the liver, then let's absolutely try to do that. But I felt particularly a charge to try to figure out the puzzle of what can we do through other means to try to convert people to be a candidate for surgery when they initially aren't. And it turns out there's a whole specialty for that, and that's called interventional radiology, and the subspecialty now is called interventional oncology. And that's where my team spends most of its time working. And we treat the tumors, but again, what we're going to focus on today is how can we use a therapy called Y90 to make someone a candidate for surgery when they initially aren't. And I think what's important to start off with here is understanding what makes you a candidate for surgery versus not. And you have to understand the liver. So this triangle here is the liver. The liver needs a couple of things to be had. What's unusual about the liver is that it hangs out and has responsibility for the organs. So there is your stomach, which is right here. There is your spleen, which is right here. This is your bowel. And what's interesting is that your heart pumps blood into all these organs. And then they use that blood. And when they're done, they send it through a big vein. So used blood leaves these organs. One leaves the bowel, spleen, stomach, and they form this main vein. And what's unusual about the liver is that this vein then enters the liver, processes this blood. And it filters it, packages stuff that the body picks up through nutrition. And the liver is also unusual that it likes this blood supply. It actually prefers this blood supply. It likes the exhaust of other organs. That's how it likes to survive. And the liver also has another blood vessel that goes in here from the heart. That's the liver artery. It's not only two blood vessels. Bile ducts tend to like the artery, but the liver itself is not poorly. Another thing that's interesting is tumors in general. We have found over the last 20 years, they tend to really like to live off of the artery's blood supply. Now that's interesting because if I have a hallway and I have 10 doors that lead to tumor, and one door that leads to normal liver, and I take a beach ball and I throw it down the hallway, chances are that beach ball is going to end up in a door that goes to tumor. So we learned if you put therapies through this artery, it naturally sorts itself out. It's sort of the first and most basic version of a targeted therapy. Think about it, something that prefers the tumor over tumor. So we said, well, how do we mess the tumor do? How do we sort of provide therapies that take advantage? So I want you to keep that in mind. And we're gonna stop here for a second. And I want to talk more about why we have someone that cannot be resected when they initially presented with intrahepatic cholangiocarcinoma. And I'm going to focus on intrahepatic cholangiocarcinoma in particular because it's where this therapy is used most. But we have used it also for different manifestations of cholangiocarcinoma. The issue with if you can resect the tumor or not comes down to whether or not you can maintain certain aspects of the liver that it needs to be happening. So the first thing that you need to do is you need to preserve the blood entering the liver. So that's that portal vein. You then need the artery. So you need both blood supplies. And then what's interesting is there's another factor here at play called the hepatic veins. And there's 3 of them on average. These are the chimney. When all blood enters the liver, it's the leaf, and it exits these 3 vessels, and it goes back to the heart, and everything starts all over again. But you need blood going in, you need blood leaving for that liver to be happy, and one more element. And it's why we're all here, it's the bile duct. So bile duct is the exhaust of the liver. Now your body is smart and uses the exhaust to help digest food. But all of these elements need to be present for that liver to function. The problem with intrahepatic cholangiocarcinoma is that it uniquely likes to form itself in troublesome areas. It likes to form here. It's very common for us to see that. If someone has intrahepatic cholangiocarcinoma, here, a surgeon can be removed. Same size tumor, here, surgeon removes it. The exact same stage, same size tumor, here, and we have a problem. It's in Grand Central Station. That's the challenge. In order for a surgeon to successfully be able to remove that, they need a couple different things. The first thing they need is they need to have enough what we call future liver remnants. FL. What does that mean? That means that if I'm removing all of this, is this going to be enough to keep the patient happy? That's a big question. And think about this liver, if it's been subject to bowel obstruction, it's not involved still. Think if this liver has been subject to a lot of chemotherapy. That's a lot of stress in it. So those are the things that we look at and we say, gosh, is that going to be enough? Now, in order to have this much left, you have to remove everything that's involved, and you predict based on size. One of the things that we have learned is that the liver is like skin or bone. And this is where there's an opportunity. How is it like skin or bone? It can grow. So there are things that we can do to stress and shrink the portion of the liver that the surgeon intends to remove before it leaves the body. And what does that do? It tells the body, hey, you've got a job to do. You need to grow this liver. And that's, I would say, within the last sort of 25 years, has become standard for us to start thinking about an opportunity. But here's the problem, is that a lot of times we would say, well, gosh, there's a cancer, can we resect it? Let's hurry up and get the patient from OR to resect it immediately. I can totally understand that feeling. You don't want it in your body, you don't want it out. The problem is that there's two things that are challenges when it comes to surgery. One is whether or not a patient is anatomically resected. What does that mean? If I can move it where it is located and have it normal liver. And B is whether or not it's biologically resected. What does that mean? That means this. I have a tumor that, let's say, is in a spot where I said it's a good one, which is your remove. Presents as one tumor, we're seeing no disease elsewhere, we're very interested in removing it. But what if this presented like this, with multiple smaller satellite lesions? So we call that a phenotype. That means, okay, it's looking a certain way, like it's a bit more aggressive, just in the way it looks individually. And then obviously there are different biological ways that we can assess that as well. But a surgeon knows that if they rush into the surgery and they remove this, that the patient's at high risk for having disease show up elsewhere. And we don't understand that person's biology just yet. You don't understand how that cancer is going to behave in that patient. One of the best things we've seen from that is time. And so I would say around late 2010, 2011, we started saying, well, gosh, is there a way that we can shrink the liver that I intend to remove, grow the liver that I intend to keep behind, but I also don't want to rush. I want to give this patient some time to where we can control this disease. A lot of times eliminated in its vast majority to where one clinical cells are. Really pick the right patient to go to surgery, because the worst thing for you is if you need to have chemotherapy, though, man, you still don't come. So what we decided to do was look at a therapy called radioembolization. Here, let's try that real quick. How does radioembolization work? Well, what's interesting about it is that if you look at the concept of radioembolization, you're going to send little tiny microscopic spheres that contain radiation. So little tiny beads that are made of either glass or resin. They emit radiation in a very particular way. So here's a magnified version. Again, this is about 3 times the size of a red blood cell. You know that, so very tiny. And the radiation they emit only travels on average around 2 millimeters to 11 millimeters at most in tissue, and then it stops. So think of it as like a little microscopic radioactive hot coal. Walk into a room, there's hot coals over there, you're not going to feel it. It's not going to shine a light on. It is something that you feel the closer you get to it, it starts getting more intense, and if you pick it up in your hand, it's very hot. So picture that. What was useful about this there was that if you look at the liver, I'm gonna draw a liver here again. Where it's located, you have stomach near here, you have bowel down here, you have heart up here, you have a lot of structures. And it's all packed in close together. We want to grow just this portion right here. We can take this therapy, and I'm going to go back to the artery that I drew earlier. This therapy goes into the liver through the artery, and it's an outpatient procedure, and it's done local, so it's not something patients feel. You gain access to an artery near the head, just like a cardiologist does a heart study. We can do a liver study. And what we do is analyze whether or not the patient's a good candidate for the therapy on an initial step we call planning. We study with the simulation, just like any kind of radiation oncology procedure, and then if the patient's a good candidate, deemed by a sort of good blood supply, going to the tumor, and we proceed with therapy. We order the spheres, and the spheres enter the entire liver where the surgeon intends to remove. It's the first thing he does. We actually irradiate the normal liver on purpose. Why? Because the radiation over time causes that liver to scar up, but it does it slowly, so it's training wheels. It's a nice slow transition of about 3 months. The body begins to slowly pick up speed, and the proportion of the liver smooth out. That's the first thing it does. So that's growth. The second thing it does is I mentioned there's a tumor here. And guess what? Cholangiocarcinoma does not like radiation. The radiation that we can get in here, when we measure it, sometimes 10 times of what we can see that can be delivered with external beam radiation therapy. Doesn't mean that it is superior to it, it's just a different way of delivering it. And our team collaborates together with radiation oncology to determine what's the appropriate energy for a particular situation. But what's useful is that this tumor has a very high chance of responding, shrinking, losing its blood supply due to very high dose radiation. So you have time to grow this portion of the liver, and you have time to watch the patient if they're higher risk. And that's been sort of extremely impactful to patients who are deemed initially unresponsive. Is that you can go in, you can have an outpatient procedure. It's already treating your tumor, even before you initiate systemic therapy. It's remodeling your liver, and it's increasing confidence in your multidisciplinary care team, especially your surgeon, that they're going to do you a positive service to take the field. Why? Because they don't want to have someone have early progression. They don't want to have what we call post-hepatectomy liver failure, which means I removed it, and you are struggling with having normal liver function. You can't leave the hospital. And post-hepatectomy liver failure can happen even in some of the other ways that we've used to grow liver in the past. We have seen it very low. In our published experience, it's 3%. As historical, something's close to 20%. Why? Because as this is being irradiated, this tissue can be evaluated with some of these really cool imaging agents we have to determine, is it even doing anything for your body anymore? If I show a surgeon that this liver is non-functional because of the radiation, I don't even care what size this is, because the patient's doing well, that's all we need. So personalized. So what I'd like to next switch over to some pictures so I can show what this looks like in practice. All right. So if you look at this picture here, standard external beam radiation therapy that's done with an X-ray or a photon, you can see there's sort of a really nice area where it's bright red. That's where the dose is really high, where tumor is. This is sort of colder blue area where there's a little bit of radiation that leaves that area, but it's much less intense. You may have heard of charged particle or proton therapy, or we're building a carbon center in Mayo Clinic, Florida. It looks like this. So it's really nice and bright, and there's an entry dose and an exit dose. And basically the radiation enters the tumor and then slows down on the other side. But if you look at Y90, these are little tiny radioactive hot coals. They enter the tumor and they exit, and there is no entry or exit dose. It's from within the tumor itself. So that's how these look differently if you look at how the radiation behaves. So mentioned a couple of advantages here. It's very high dose. It's 1 to 2 sessions. You can treat very large volumes. We treat over 80% of the liver sometimes with this, and people have good liver function. Challenging anatomy. This is used as a problem solver for difficult cases. This is specifically designed for that, and it remodels liver. The downside is we have to do a procedure to study the blood supply, determine if you're a candidate for it. This is an older trial, but it's phase 2 evidence of first-line treatment with Y90 in a palliative set. This was not with the intent, what we call a radiation lobectomy, which is where we're trying to remodel the liver. This is just pure trying to control the disease on its own. And what caught my eye was that number over there. 20% of patients with palliative intent were converted to surgery. That's an opportunity. We need to figure out why that happened to those folks and what we can do to make that higher. What was interesting was how well the patients did that were converted to surgery who were initially deemed unresectable, palliative intent. So the goal here is to increase access to the gold standard of surgery. So again, to recap, what is a radiation lobectomy? It looks like this. You have a high-risk tumor in one side of the liver, not enough liver on the other side. We treat it with the Y90. It shrinks the tumor and the normal liver. It grows the other side, and the surgeon comes in and removes it. What does this do? Allows you to treat tumor, grow liver, and again, for higher-risk patients, that confident test of time that we know with a high degree of confidence you're running in. So I mentioned before, we had published our experience with this, and over just under 90% of the patients that were in this study, which is a retrospective study done at Mayo Clinic, these are folks who had failed to have enough growth generated with other means. And this was a salvage. And we had one patient, the entire study, that had transient liver failure. That was it. So again, very, very high degree of confidence that if you do well with this therapy, you will do well otherwise. Now, I want you to see this picture here. See how the liver is bright and it's dark in this right side where the tumor was? That's an agent that determines your liver's ability to process bile and produce bile. And if it's dark, it means that it's not doing that for you. That person is already living without that piece of liver. It's basically a big ball of scar. And this person did extremely well after resection, as you can see in that picture. So how do we use all this to help a patient? I'd like to show you an example. This is a patient with multiple satellites, very aggressive biology. And when the surgeons looked at it, they said, we need this portion of the liver to remain behind. So we did this concurrent with systemic therapy, and we performed a mapping procedure. And this is what that looks like. You'll see these little lightning bolts that head over to the liver, and you see this little wedge pizza slice. We're building puzzle pieces, just like canopy in a tree. If you were to prune a branch to see what portion of the canopy goes to it, we assemble all those together and make a comprehensive liver picture. And we administer individual Y90 doses to all those branches to tailor it to the surgical plan. We published our experience on doing high dose, so what we call ablative radiation in these patients. And what we found was that if you map well, that's a biomarker. It actually affected your outcomes. So everyone in our tumor board now gets mapped, just like we test for a mutation. And then we say, okay, we come after mapping. If you look good, then we proceed. So not everyone gets this. It's about 14% of patients that don't get this, i.e. they don't have good blood supply. But it is something that we've seen is definitely necessary. And when we treat this, what you're looking at here is the actual radiation that's picked up with something that's similar to a PET scan. You can see there's radiation in the tumor, and then we put radiation in the normal liver to slowly remodel the liver. It turns into scar tissue and grows out of the side. We treat tumor, we grow liver, and this is a scan that we do in 6 months. What's glowing bright here is actually whether or not this liver can produce bile. So you can see the only part that's actually physiologically alive in this patient is the portion the surgeon is going to leave behind. But look how much it's grown in that 6 months. High degree of confidence going to surgery. Here's that scan that I showed you where it's dark, the liver's not producing bile. And now that little red triangle is this big green triangle. This patient's ready for surgery. When they went to surgery, over 90% of the tumor was completely treated. So again, we had no progression. We actually had the opposite. And the patient was discharged 5 days after surgery with no liver failure. And years later, as we will unfortunately see from time to time, a patient will have a recurrence in the liver. But guess what? They have a lot of liver now, where the surgeon could go back in and remove the lesion. So this is now in the NCCN guidelines. They actually recommend using Y90 as a means of downstaging patients to surgery. So this is now standard of care. What was crazy 15 years ago is now in the biggest guidelines in the United States. What I want to leave you with to close up with here today is, what if someone is not resected? We do see those patients. Here's an example. This is this is about a 7-centimeter tumor, but it's in the worst possible location. It involves both bile ducts, where they branch, which is a problem, and it involves all 3 of the chimneys, the hepatic veins. This is one of the toughest types of cholangiocarcinoma to remove surgically. We enrolled this patient in a clinical trial where we said, we're going to give you immunotherapy and Y90, and we're going to follow you. And if you do extremely well, part of our plan was we were going to potentially list this patient for liver transplantation. Now, historically, we stopped at around 3 centimeters, right? This was more than double that. But our philosophy was, if a patient does really well, what does that mean? No evidence of disease progression a year after treatment. Then we think this is probably a better patient than someone who is being transplanted on the front end with a 3-centimeter cholangiocarcinoma because of that test of time. That's exactly what we did. And this is what the tumor looked like at the 12-month mark. So it's dark because there's no blood supply going to it. That's a good response marker for us. I don't want to minimize this patient's experience. Having your bile ducts involved like that is extremely tough. And this patient had to have stents and had to deal with infections. And I do not want to minimize that. However, it was the appropriate patient who was well informed of that and was confident that this was the right approach for them, and we proceeded with it. This patient was subsequently transplanted, and we were very surprised to find out that in the liver that was removed, there was no evidence of viable tumor left. So it was what we call a complete pathologic response. Did he still need the transplant? Absolutely, because we cannot use that as a replacement for surgery. But it lets us know that it was well controlled while we were waiting for that time being. And the patient is now in the first year after transplant without evidence of disease recurrence. So in summary, patients can have different challenges to become resectable. We mentioned biological and anatomic resectability. Y90 lobectomy can help mitigate all these things as part of a multidisciplinary approach to get people to standards of care. And every patient should be optimized for their unique opportunities, which requires that granularity. I can't take what we did in any of these cases and put it in a formula. That's why we need societies like the Cholangiocarcinoma Foundation to help spread education and awareness. Why? You have a team that's passionate for this. You will see if those opportunities are available. And I think that's the way forward with this condition. Thank you, everyone.
Thank you so much, Dr. Droskich. I mean, that was phenomenal. I know it reminded me of my medical school and training days, right? With the whiteboard talks, right? Which blood vessel goes in, which blood vessel goes out. And that was really important for our patients, for everybody to know. I'm sure I learn a lot every time I speak with you. And the great thing about Bo is he speaks at scientific meetings and he talks complicated language. And then when it comes to the patients, I think he talks the patient language. I think that's a great skill to have. So now I'd like to welcome Dr. Robbie Cannon to introduce our next speaker, Dr. Saul Shea.
Hello, so I'm really pleased and honored to welcome and introduce my partner here, Dr. Salat Sheikh. So I got to meet Salat when she was a fellow here, and I had just started as a liver transplant surgeon, and we were lucky enough to get her to stay. And when I say Salat is the real deal, I mean it like no other surgeon I've ever met. She can do it all. She's a liver transplant surgeon. She is leading the growth of our living donor liver transplant program with our planned first patients here at this center next month, which is really going to open up options for all sorts of patients who otherwise need a transplant but don't have access to it because of the deceased donor list. She's an incredible hepatobiliary surgeon, does all these wild resections like Bo just showed you. Salat can do it. And Beyond that, she educates our patients, she educates our students, really just an all-out asset and a jewel for us to have here, and really just an honor to work with her and work alongside her. So looking forward to hearing what you have to say. Welcome.
Morning, everyone. Can you hear me? Okay, awesome. I'm gonna try not to stand behind the podium because I'm vertically compromised. So I do like to see people, so I'm gonna try to stand on the side. So I'm gonna, Dr. Jose's talk was perfect to segue into what I'm gonna talk about, is because he sort of helps set the stage for what we try to do, which is get the patient to surgery, which, as we talked about, is the best option that we can try to hope for. So we're gonna follow these list of things. So we're gonna talk a little bit about the basics of the bowel duct cancers. There will be some overlap, so I'll try to go through those really quickly and then kind of understand where and how surgery fits in. And then we'll talk about the surgical options, the recovery, and possible complications, as well as alternative options. So I have no financial disclosures. So I can't do the drawing stuff. That part of my brain is missing. So I'm going to just try to show you images. So everything that's green up there is what is relevant to our talk today. So there are parts of the bowel duct that live in the liver. There's parts that's somewhere in between, the bridge. And then there's the extrahepatic part, which is down below, which is also known as the common bile duct. And then in a little bit more detail, we have the right and left hepatic ducts, which are the intrahepatic ducts. Treatment in all of these options, in all of these locations will differ, which is why the location is really important. So the intrahepatic duct, you can see there's little tumors that are mass forming in the periductal infiltrating tumors. There's the intraductal tumors, the perihilar, and the extrahepatic ones. But 10 to 20% of the cancers will be intrahepatic. Those are the ones at the very top. Then you have about majority of them, 50% or more, that are in between the liver and the extrahepatic part. And then you have the ones that are close to where the bile duct inserts into the duodenum. And really what's important about all of this is that sadly, a lot of these times patients are asymptomatic. So this allows the tumor to grow without really causing any symptoms or having the patient reach out for medical care. Sometimes the patient can present with biliary obstruction, in which case they'll have signs of jaundice, dark urine, some itching, pale stools. And then sometimes, rarely, patients will present with symptoms of chronic liver disease. So not necessarily the cancer itself, but signs of liver failure that are associated with like enlarged spleens, ascites, and encephalopathy. So who might be at risk? So who do we need to screen for, or who do we need to look out for? Majority of the time, these is a low incidence tumor. There's only about 2 per 100,000 annually. In endemic regions like the Far East, there are higher risk patients. And then some patients with underlying disease like primary sclerosing cholangitis, Caroli's disease, hepatolithiasis, or cirrhosis can sometimes be at risk. But what's important is that majority of the patients have no risk factors and therefore have no cause of concern to look for this problem. And therefore, the diagnosis is often delayed. When we identify these cancers early, most of the time it's because they were incidentally found. The location is deep, the liver has no sensory, there's no sensation, so there's no pain associated with it. And sadly, the symptoms appear when diseases are advanced, and it includes the deaths. So how can we make the diagnosis? Most of the time, we will start off with blood work and tumor markers. They're not entirely sensitive or specific to this particular disease process, but it's like a piece of the puzzle. Then there's a variety of imaging scans that we do. So there's CTs, MRs, and MRCPs. Patients often find these times very overwhelming because there's so many tests after test after test, and the diagnosis is very difficult because really not every single one of them will necessarily demonstrate the things that you're looking for, and you often need the entire conglomerate or collection of these testing to be able to make the diagnosis. ERCP is endoscopy, where the advanced gastroenterologists will go in and inject the dyes into the bile ducts to look for any abnormalities or evidence of irregularities. They can also perform something called cholangioscopy, where they go in with a smaller scope yet and then try to do like a direct look into the bile ducts to see for abnormal tissue. And then they'll try to do biopsies for us. And the biopsies are really frustrating because oftentimes, while they can be very specific, if they turn positive, they're not very sensitive. And that makes it very difficult when we try to work with the patients to help them explain that, okay, well, we've done a biopsy, but we still don't have a categorical or a definitive diagnosis for you yet. And then there is a testing that we do for patients, and the easiest way to explain the FISH testing on the biopsy samples is to be able to understand the genetic code of the cancer and try to increase the sensitivity of that diagnosis. And then the patient is faced with a lot of treatment decisions and dilemmas. So you can see there's many different pathways. It's a very individualized treatment, which we started talking about earlier. And the treatment pathways can differ based off of the time that you present, what your underlying comorbidities are, what the age of the patient is, and what the extent of the disease is. And therefore the importance of the multidisciplinary team. So I wish we sat in a fancy looking room like that with glass windows and look cool like this, but that may not be how we sit, but we do all get together and talk about it as a group. So there is the involvement and the role of the liver surgeons, which is us. And then within that subset, there is the transplant team. Then we have medical oncology, radiation oncology, the interventional radiologist, advanced gastroenterologist, pathologist, the oncology navigator, and a palliative care physician. So there's a lot of ifs in there, but really everyone has to provide their level of expertise to be able to help come up with a individualized treatment plan for that particular patient. So then again, surgery is the best, as we alluded to in the earlier talk, and that is if you are a candidate and how we can make you a candidate for that. So when can surgery be possible? This is really the conversations that we have in our multi-D meetings, is that it really is the Goldilocks dilemma. So you need to have just the right amount of cancer to be able to have the surgery to have the best outcome possible. So some of the things that we look at is the location of the tumor. It's location. Do you have any disease that is beyond the liver? Do you have involvement of the blood vessels? All the fancy pictures that we looked at with the dual blood supply of the liver, what the extent of the involvement is. And then do you have adequate liver reserve? So will you have enough liver left behind after the surgery to be able to sustain life until the liver can grow? Because it's great, we can take the whole cancer out, but then are you going to have enough liver to be able to live off of it? So the liver reserve. Now the liver reserve for every single patient is different. And the underlying health of the liver does matter. So there's the thing that we look at is the future liver remnant. It's the FLR. And the way we start off by looking at it is to do something called the CT volumetrics. Now you'll see over here that, like we said, that the amount of liver that's left behind is, that is necessary to leave behind is different for different people. But the majority of the patients that are going to present with this disease process are going to have some kind of underlying liver damage, either related to the treatment or because of the liver disease itself. So the amount of liver that they need will be different and more or less based off of that. This is sort of what the volumetrics would look like. The radiologists will use a cross-sectional imaging to be able to create a line and tell us sort of how much each part of the liver is of. And then there's a procedure that we can sometimes consider, it's called a portal vein embolization, where you knock out part of the blood supply of the liver that involves the tumor to allow the other side of the liver to grow in about 4 to 6 weeks. Similar principle really that we talked about earlier, but it's just a different vessel that we're targeting, and also the timeline is different. We let the liver do its magic and then it grows over time. We will rescan, redo the volumetrics, and then plan for surgery if there is enough liver remnant. So like we talked about in terms of the tumor location, the location will determine all the different surgical options that we have. There's if the tumor is intrahepatic, so it's all located within the liver, we will do just a liver resection. We can do a combination of liver and a bile duct resection. Sometimes it involves doing a Whipple procedure, which I'll show you here shortly. And then there's the option of a transplant, where you remove the entire liver and replace it with a new one. So these are the different resections that we can do. There's depending on, because the blood supply of the liver is so unique, you can take out parts of the liver and leave others behind without affecting its blood supply. So the lighter color is the parts of the liver that you can remove. In some parts of the intrahepatic cancers, you have to remove the liver with portions of the extrahepatic bile duct and do a reconstruction, like so. The blue parts in this picture are the ones that are removed. Rarely, it's possible for us to just remove the extrahepatic bile duct and do a reconstruction with the envelope of the bowel. That's basically to allow the bile drainage from the liver directly into the intestines. And then the distal part of the bile duct, if it's involved, it does require removal of part of the head of the pancreas and the small intestine, which is all colored in blue. With a reconstruction noted on the other side. These are really big operations with a lot of recovery that the patient needs to go through, and we'll talk a little bit about that shortly. So liver transplant, near and dear to my heart. That's what we do most of the time. There are two different kinds of liver transplant that we need to consider. There's the option of deceased donor liver, where you can get a whole liver transplant, so you replace the entire diseased liver with another whole liver, versus the split liver option. Now, as we first talked about, there is the problem of limited organ availability to be able to offer this option to everybody. And that's where the role of the living donor liver transplant comes in. That's based off of the premise that you're able to remove about 60-70% of somebody's liver, leave them behind with 30%, and that part of the liver will grow. And the removed part can be implanted into a recipient, and that will also grow and accommodate their needs. So eligibility for a transplant is again the Goldilocks dilemma. There is a very strict criteria for who will be able to benefit from the operation. And really the reason for that is that you want to be able to remove the cancer or the abnormal cells in its entirety for the patients to have the benefit of it. So for perihilar cancers, we look at the tumor size of less than 3 centimeters. There should be no nodal disease, which means that the tissue that's around the liver, we will sample them at the time of surgery to make sure there's been no spread that we were not aware of. There has to be no distant metastases, so there has to be no disease in the liver, outside of the liver, like in the lungs. Oftentimes, these patients will undergo treatment ahead of time. That can include chemotherapy, radiation therapy, and Y90 therapy. And then they will remain on some sort of a chemotherapeutic agent up until the time of transplant. A newer indication for transplant is the intrahepatic cholangio. They do get exception points from the society. These tumors have to be small with underlying liver disease. The disease again has to be limited to the liver. It has to be responsive to the treatment that they've had ahead of time, and it has to be stable for the last 6 months at least. Transplant is not an option when there is any of these factors listed. So lymph node metastases, extrahepatic disease, if there's been any progression while the patient has been on treatment, or there's any peritoneal seeding. And really, it's not about trying to exclude patients from the transplant opportunity. It's more that these things are indicative of cord biology of their particular cholangiocarcinoma. So in terms of preparing for surgery, if somebody is a candidate for that, important things that are noted here are nutrition. So the concept of prehabilitation for the patient to optimize their health as best as possible in terms of their physical strength, their nutrition, protein intake, and then as well as managing their comorbid conditions like high blood pressure and diabetes. And then if they have obstructive disease from their cholangiocarcinoma, to be able to drain the liver well with things like PTBDs, control infections, cholangitis, to be able to give their liver the best chance to recover after the surgery. That's sort of what a PTC or PTBD might look like. The day of the surgery, it's a major operation, it requires general anesthesia. There's often a need for blood transfusion. It's about a 4 to 8 hour surgery, depending on the extent of the disease, the treatment that the patient might have had ahead of time, which would cause like scarring and inflammation. We'll do intraoperative frozen sections, so we'll take portions of the bile duct and make sure that the end that we've cut off is negative for disease to ensure that we've gotten everything out. That's called an R0 resection. And then there is possibility for us to not proceed with surgery if we feel that there is that we will not be able to remove the disease in its entirety, so it would not be a curative intent. There is a role for palliative surgery, which I'll talk briefly about in just a little bit. That's mainly to control the symptoms associated with the disease rather than the actual cure of the cancer. Recovery from the surgery requires a hospital stay for about 5 to sometimes up to 14 days. There is potentially a need for ICU monitoring. Patients will have tubes and drains afterwards. There is sometimes a need for reoperation if there is a complication such as bleeding. Pain control and early mobility is important. We like to have the patient have return of bowel function. We look for early signs of infection and early signs of liver failure. So about the timeline of recovery, the patient will take about 2 to 6 weeks to sort of recover from that immediate phase, where really the focus is on diet, physical strength, and pain control. At about 6 to 8 weeks, we'll allow the patient to start lifting heavy weights, because by then, you expect the fascia to be healed as best as possible. We'll do a follow-up scan in about 8 to 12 weeks to look for how the liver is growing, to look for any recurrence of disease or any additional needs for additional treatment. There is often need for adjuvant chemotherapy afterwards, and for that, we'll partner with our medical oncology colleagues. Now, the risks of the operation, and that's what we spend a good deal of time talking to our patients about, is the risk of bleeding associated with the surgery. The liver is a highly vascular organ. It's soft, it's fragile, it doesn't like to be messed around with. So when we try to operate and do big surgeries on them, then it can bleed. The risk of return to the operating room, the risk of infection and bile leaks. So those little green ducts that we looked at in the earlier picture, the cut edge of them can leak. And then small for size, that's a big fear for the liver surgeon. So is the liver that you're leaving behind going to be sufficient to sustain life and allow it to grow over the next 4 to 6 weeks? Sometimes patients can have food intolerance, difficulty eating, difficulty keeping their food down, especially after extensive reconstructions. In the case for transplant, there is always the risk of rejection over these additional other risks of surgery that we talked about. The need for lifelong immunosuppression, opportunistic infections, and then sometimes, rarely, there's something called primary non-function where the new liver that's been put in just doesn't work. So I debated a little bit about putting this up because I think sometimes the numbers look a little bit dismal, but overall with resection, you can have about a 40-month overall survival, 25 to 70, as high as 70%. And then with transplant, it is possible to have a really good survival because, you're demonstrated that you've removed the entire tumor. And then for intrahepatic cholangio, the 5-year survival can be as high as 65%. If surgery is not an option, then it requires collaboration with all the other, multi-team that we talked about. There's chemotherapy, radiation options, additional liver targeted interventional therapy, clinical trials, and then also palliative intent, endoscopic stents, PTVDs, and bypass surgery. Thank you.
All right, thanks, Dr. Sheikh. I really want to thank you for such a wonderful and reassuring talk. I really wish we have that fancy room, Robbie, for our multidisciplinary discussion. But I have a photo in my slide.
Still in here?
No, right, we need our dean. But we are really focused towards our multidisciplinary care, keeping patient in the center. That's the motto that we work with, and beyond Dr. Sheikh's surgical expertise, what truly stands out is how deeply she cares for her patients, right? She's committed to improving the transplant care for patients across the state of Alabama. From the medical oncology side, we keep budging and reaching out to both Robbie and Saulat for questions, and they respond within 24 hours. I know they have much busier schedules than what we do, but that's the level of collaboration. It makes a difference, right, in our patients' care and team. I also really want to recognize Gina and Marshela. They are great coordinators. Without them, I think the multidisciplinary care don't exist as well. So thanks so much for what we do. Right. I would like to invite Dr. Elisa Knight to introduce the next speaker, Dr. Rosamund Jacob.
Hey, good morning. It's my pleasure to introduce Dr. Jacob. He's the chair of radiation oncology at University of Mississippi Medical Center and tenured professor in the field. He's internationally trained He has leadership roles across the US, UK, India. He's also delivered more than 50 invited lectures worldwide. He has mentored over 80 radiation oncology residents, definitely expanding his field. And he serves on national committees, including the NCCN Hepatobiliary Panel, which helps shapes our guidelines and advances cancer care at its highest level.
Thank you for the kind introduction. Hello, everybody. To me, it's a great pleasure to address you all, and even greater pleasure meeting all my old colleagues. I spent almost 20 years at UAB before moving to University of Mississippi, which was 18 months ago. So to me, today's meeting is a fruition of a lot of years' hard work in building up the multidisciplinary team. I'm extremely grateful to meet several members of the multidisciplinary team here. Thank you for the great work you all do. And thank you for the fantastic work the Cholangiocarcinoma Foundation is doing. Thank you to you both for your kind invitation. So I think you guys had enough of anatomy and physiology and all that, so I'm going to keep my talk very simple and keep it very oriented to practical aspects of how radiation can help take care of cholangiocarcinoma patients. So we have seen the vital role surgery plays in curing, controlling cholangiocarcinoma. Surgery is the most important treatment, the most effective treatment. It takes care of gross tumor. The surgeon resects everything that he can see, everything he is figured out or mapped out on the scan. It is possible, however, that there could be microscopic disease left behind, things that the surgeon cannot see with the naked eye. And we know from our experience dealing with patients who have local recurrences and also looking at pathology specimen that there could be microscopic disease around the tumor, and that's where radiation comes in. Radiation also takes care to sterilize the lymphatics where microscopic cancer would have spread. So radiation comes as a secondary treatment to surgery. Post-operatively, radiation is good to sterilize the operative field. Chemotherapy or systemic therapy, we all know nowadays medical oncology deals with not just the chemotherapy drugs. There are a number of biologicals, a number of immunotherapy options available to treat cancer. Those are all systemic therapy, very effective because they circulate throughout the body through the bloodstream, and they can sterilize microscopic disease, which could have spread to distant sites like lungs, for example, or other parts of the body. So, I did not mention interventional radiology here because there's a lot of overlap between radiotherapy, external beam radiotherapy or interventional. But these are the three major treatment modalities that is used to treat cancer. And in cholangiocarcinoma, we often need all three. There are some cancers where you only need one. For example, there are some lymphomas and leukemias you just treat with chemotherapy. There are some skin cancers you just do surgery alone or radiation alone. But in cholangiocarcinoma, the nature of the cancer is that you need all three treatments most of the time. Now, what is radiotherapy? Radiotherapy, also called radiation therapy, is a medical treatment which makes use of high energy rays. Most commonly, we make use of X-rays. And you're all familiar with X-rays. X-rays are used for diagnostic purposes. We have CT scans, X-rays when you fracture your arm. It's the same kind of X-ray, just that you're using a much higher energy X-rays to go in and kill cancer cells. And these rays go through the tissue and kill the cancer cells through DNA damage. Cancer cells generally have a tendency to grow fast, reproduce quickly. They have a lot of DNA being produced. The X-rays have a unique tendency to cause DNA strand breaks, which cannot be repaired by the cancer cells, and that's how damage occurs. Oftentimes, as I mentioned, radiation is used concurrently along with systemic therapy because chemotherapy or other systemic therapies have a tendency to sensitize radiation, make it more effective. It's called radiosensitization. So we make use of the unique property of radiosensitization to increase or improve our outcomes. Now, how can external beam radiation be used to treat patients with inoperable cholangiocarcinoma? So that's the topic which was assigned to me. And I think there are three ways external beam radiation can be helpful. And I'm going to show you three different clinical scenarios, three patients that I have treated while I was at UAB, and explain how these patients were helped. The first is a patient with advanced cancer. The patient had a lot of symptoms from cancer. Patient had seen the surgeons. It was felt that the surgeon cannot effectively remove the tumor and cure the patient. So we used a palliative form of treatment for this patient. The second was a patient whose cancer was inoperable, but still, by and large, the tumor was confined to that area. It had not spread to other parts of the body. Patient was relatively in great performance status. He was still very active. He actually had a business he was running. So we thought he's a perfect candidate for more aggressive treatment. Even though we knew that eventually this patient is going to be, we're going to succumb to this illness because we are not able to offer him a curative surgery. And the third scenario is a patient with a very early stage cancer. He was a surgical candidate, but the surgeon decided not to operate because the patient was very reluctant to undergo surgery. We tried to encourage the patient to undergo surgery. The patient said, no, I don't want to do surgery. And there are also situations where sometimes a patient may have other comorbid conditions where surgery is not safe. So in these cases, you can offer curative treatment using radiation. So I will go through three different case scenarios. The first patient, Mr. S, was from Birmingham. He was 68 years old. He came to the hospital with abdominal pain, jaundice, severe fatigue, weight loss. CT scan showed he had biliary blockage. Biopsy showed cholangiocarcinoma. While all the staging workup was happening, he started getting lots of pain in the back, and he had increasing pain in the abdomen. So we did a spine CT. We found that patient had metastasis in the lumbar spine. Due to the advanced nature of the illness with metastasis, it was felt that surgery is not a feasible option. So we considered palliative radiation. His performance status was not very good. He was bedbound. So we gave him 30 gray in 10 fractions meaning 10 treatments over a 2-week period. This is a palliative treatment aimed at controlling pain and other symptoms. After about 4 or 5 treatments, the patient started getting excellent pain relief. And by the end of the treatment, he had no pain. Unfortunately, we could not relieve his biliary obstruction, so we had to send him to interventional radiology to get a stent placed. So this is a classic example of how radiation can help to relieve symptoms in patients who have inoperable or even metastatic disease. And unfortunately, a lot of patients with cholangiocarcinoma would need this kind of intervention. So let's see how this effect takes place. Radiation can shrink the tumor. If it is blocking a bile duct, it can often relieve the blockage. Unfortunately, it didn't happen in this particular patient. It can reduce pain if the tumor is pressing on nerves and other organs. It can slow the cancer growth. And once again, the aim here is not to cure the cancer, but to make the patient comfortable, improve quality of life, and maintain a good status till the disease progression happens over time. Patient number 2, a patient with locally advanced cancer but inoperable. This is Mrs. A. She's 52 years old. She also presented with the same symptoms: abdominal pain, loss of appetite, jaundice, weight loss. Workup showed elevated bilirubin, elevated liver enzymes. Ultrasound showed biliary ductal dilatation. MRI confirmed that the patient had a locally advanced tumor. It was involving the adjacent vascular structures, making it unresectable. The surgeon said, no, we can't remove it because it it is infiltrating the major blood vessels. But on detailed workup, we couldn't find any distant site of disease. Everything was localized, confined to one area. We did the biopsy confirmation, placed a biliary stent to relieve the jaundice, and then we offered the patient high-dose loco-regional radiation with concurrent chemotherapy. As I mentioned earlier, use of chemotherapy is very important here because chemotherapy tend to sensitize the radiation, make it more effective. So we used a chemotherapy called Xeloda, capecitabine, which was administered in the oral through the oral route, very well tolerated. We went ahead and treated a slightly bigger volume, including the lymphatics, initially to 25 treatments, and then we treated a smaller volume to an additional 5 treatments, total 30 treatments. So unfortunately for radiation, it's a very strong treatment and it has to be broken into small doses and given over several days. So that is mostly considered a taxing thing for the patient to come back for treatment. The actual treatment each day only takes about 10 or 15 minutes, but the patient has to come back. This treatment was very well tolerated. Patient had mild nausea. He had a little bit of dehydration. She had a little bit of dehydration. So we had to hydrate her a couple of days, but she did very well. The tumor was controlled when I last gathered her information about 26 months later. So this is the second scenario where radiation can be used to control tumor for as long as possible while maintaining good quality of life. The third case is another gentleman with cholangiocarcinoma, age 56. Once again, the same history of presenting illness. He had mildly elevated tumor markers, mildly elevated enzymes. His MRI demonstrated a 4.2 centimeter solitary mass in the liver peripheral location without involvement of the hepatic hilum, bile ducts, etc. Biopsy confirmed intrahepatic cholangiocarcinoma, no distant metastasis. So this patient had a relatively early stage localized tumor in a favorable location. Surgery, unfortunately, was not a feasible option for this patient. And the question was, what could we do to control this tumor? So there is currently published data suggesting that high-dose radiation, very high-dose radiation, can indeed control these tumors long-term. There's a very good publication from JCO. I'm sure all the medical professional here would know about that paper, JCO paper from MD Anderson. So we used the same principle to treat this patient. We used 67.5 gray, which is a very high dose. This is the high dose area depicted in red in the center. Over 15 treatments over 3 weeks. The periphery of the tumor got a much lower dose, 37.5 gray. We were able to spare a significant volume of normal liver. No concurrent chemotherapy was offered because we thought the radiation dose is sufficiently high. There was no need for concurrent chemotherapy, and that's what the clinical trial published from MD Anderson had done. So we were essentially replicating the MD Anderson experience here. Patient tolerated the treatment very well, and he did very well at the end of 21 months of treatment with no evidence of tumor occurrence. So that brings to the question, can you really do this treatment safely? Isn't that high dose? Doesn't radiation cause a lot of side effects? I want to highlight that the modern radiation oncology equipments, the new linear accelerators, all have very sophisticated imaging technology associated with this. It is capable of taking images on a daily basis to accurately line up the patient. It is capable of imaging during the process of radiation to make sure the patient does not move. And if the patient does move, the machine can be automatically interrupted. It also has the ability to track breathing so that you can modulate the treatment or get the beam to switch off depending on the window that you set to treat patients. all in all, this is not the radiation oncology that we probably encountered 20 years ago. And I've seen this transformation over my career. Treatment today is extremely complicated because of advances in computing, advances in imaging. So it is possible to do all these advanced treatments and still limit toxicity. Now, if you have a really small tumor, can you do the same treatment over a smaller number of fractions instead of bringing the patient for 3 or 5 weeks? The answer is yes. Now we have a technique of radiation treatment called stereotactic radiotherapy. For selected patients, we can offer 3 to 5 treatments and still deliver the same amount of dose and get the same control of tumors. So these are the different options we have to treat these patients. Now, can you improve outcomes even more? I think we can by effectively combining the appropriate systemic therapy with the radiation. You can probably improve outcomes even more. Like the first speaker mentioned about utilizing biological therapy with Y90. Using the same principles, you combine different modalities, you can get a synergistic effect, and you can probably improve the outcomes even more. And it's not easy to do these clinical trials, and that's where the Cholangiocarcinoma Foundation could come help. And that's why we need to collaborate in an interdisciplinary fashion to do these clinical trials and evaluate the outcomes from using these combinations. So as we said, radiation can be used to shrink or stop tumor growth. It acts through the DNA damage. Targeting is way more precise than it used to be. And you can often combine with chemotherapy or other systemic therapies. And we should evaluate systemic combination with radiation more often. Pros and cons. So even if the tumor cannot be cured, there are situations where radiation can help to slow tumor growth and relieve symptoms like pain and jaundice. Modern radiation treatment can avoid treating normal liver, reducing the likelihood of radiation toxicity. Radiation can be combined with chemo or systemic therapies. The downside, as I mentioned, multiple treatment visits. So there is a reason to consider reducing the number of treatments. That's what most of the centers are currently doing. Radiation has side effects, mostly tiredness. There could be some nausea, vomiting because of proximity to the stomach. Oftentimes well controlled with medications. And in summary, radiation can definitely help relieve symptoms. Radiation can slow down cancer and help patients live longer when surgery is not feasible. In some cases, high dose radiation can even cure cholangiocarcinoma in properly selected patients. Radiation oncologist is an integral part of the care team. It is important to consult the radiation oncologist as well to discuss what treatment options are available. There are different types of treatments, different types of machines. Not all treatments are available in all centers. That's a very important thing to understand. Some treatments are available in all hospitals, whereas the most sophisticated treatment, especially the one where you are controlling treatment according to your breathing cycle, or you're doing very high precision 3 or 5 fraction treatment to very high doses, they are only available in the best centers where the technology exists, the expertise exists. So it's very important to talk to the radiation oncologist and find out what is available. And it's also very important for the foundation to spread the word that radiation is a good treatment with the option of cure in a few patients with the opportunity to palliate in most. Thank you once again for the kind opportunity.
All right, thanks, Dr. Jacob, for delivering a great talk. And we miss you at UAB. We still enjoy our conversations when you're here, but I'm sure University of Mississippi is lucky to have you. So with I think what if I may request our speakers and the chairs to take the chairs here, please, and there's now we'll open it up for questions. I'll have a mic. Melinda, I'll hand over this to you.
And you guys have one up there?
Yeah, there's one up there for our speakers, so feel free to ask questions. Perhaps I'll go ahead and get started. I think the theme of this session, I understand, is patient selection, right? I mean, it's really important to identify a patient to determine which therapy we're going to start first, and then what is our goal. So I'd like to start with, both Robbie and Saula to give us in terms of how we handle our patients. Like I know you get most of our referrals here. What are the next steps as we get our patient referrals, and how do you help us, take us in that process?
Yeah, so ideally, we kind of want everyone to meet the whole multidisciplinary team at once. That's, we have Dr. Mehmet Akçay here, and he was really instrumental in sort of helping build our multidisciplinary clinic. So sort of the traditional pathway is you would get referred in to the surgeon, and then, we'd meet you, but then we'd have to wait till the end of the week. We'd meet in our chamber board, usually kind of sitting at our desks on Zoom rather than in a nice pretty room. But then patients would all have to come back and go see all the individual specialists. And, that can be a real challenge when you're coming from 4 or 5 hours away. You got to take time off work. You have family members coming with you. And so the ideal process, which we've started now, is actually we sort of get everyone together in the same room. So when you come for the clinic visit, you'll meet the surgeon, you'll meet the interventional radiologist, you'll meet the medical oncologist, you'll meet the radiation oncologist. And what we'll typically do is sort of review all your case records ahead of time. So ideally, we'll be looking at your CAT scan, we'll be looking at your records from the referring doctor. And so we'll go ahead and have a preliminary plan. Okay, these are what we think the potential options can be. And then everyone will sort of go in one at a time and sort of talk to you and kind of get your story and also solicit your preferences as well, right? Because oftentimes there are more than one options that are available. I think Roji talked about the patient, who maybe could have been a surgical candidate, didn't want a surgery. That's very common, right? I think the approach we like to take is, what do you want, right? Because not everyone wants surgery because it's a lot to get through. There's a lot of potential downsides on the end, and there is, a very real risk. It may cure your cancer, but if you die of surgical complications, that didn't help you. Some folks want to take that risk and some don't. And thankfully, that risk is very low, and kind of the care has gotten better and better. However, I think people value different things. Some people say, man, I really just want to see my grandkids graduate from high school in the next 3 years. I want good quality of life between now and then. And I'm not trying to go make it another 10, 15 years. And I don't really want to be kind of having the suffering and pain scars. And that patient may choose for something sort of a little more palliative, something that's a lot better tolerated, that's going to get you that good 3 to 5 years of good quality of life, and maybe not trying to go knock that apart. Others might say, yeah, I'm 40 years old and have 2 babies, let's do everything you can. And that really changes your treatment paradigm. But it's really helpful to have all members of the team there to meet the patient at that time. And really that way you can hear from everyone and hear what all the options are and decide what's best for you. Because at the end of the day, there's not one best treatment. There is one best treatment for you. And it may be different for you and for the next person.
Next, feel free to ask questions. Yeah, there we go.
Janine, I enjoy technology, but I have questions for you in the selection for surgery or therapy. Your initial diagnosis, is I noticed several times you have showed the CT, and one time shows MRI with contrast enhanced. Why not start with contrast enhanced?
I'm going to say a little bit on this because, every imaging modality shows something different and shows some parts of the things better than others. So as surgeons, I think we like to look at CT scans because they're very helpful for surgical planning because it shows you the vascular anatomy a lot more clearly to our simplified reads, not the radiology, but the simplified read. But then the MRs are very helpful in helping, like in terms of the sensitivity for the biobank itself. So I think I like to explain this to the patient as they're all pieces of the puzzle. So they all put together one big fancy picture that we're trying to look for. And by themselves, they will say some part of the story, but not the whole part of the story.
It's a quick follow-up, because we developed a targeted contrast agent with traumatic increased sensitivity and laxity. So this is why, in your situation, will it really help you if we see very tiny metastasis, much smaller, at different regions?
Yeah, no, for sure. I think oftentimes we do have high quality MRs that have the vascular contrast and also be able to show smaller lesions that the CT won't show. But the CT can just help with the surgical planning, if we feel that it's not sufficient on the MR.
Thanks for the question. I think as a follow-up, I would like to ask, oh, sorry, go ahead, Fred, please.
I was gonna ask, Dr. Kosich, regarding Y90, is it your intent to use Y90 strictly for regenerating the healthy portion of the liver, or are there other applications where you'd use it over external beam radiation? I'm asking that as patient and first.
Of course. What I shared earlier was a unique and evolving and increasingly adopted approach to use Y90 specifically because of its advantage in being able to treat large volumes of liver next to a lot of critical structures with very high dose radiation to get someone to remodel liver to get to surgery. But that came out of an experience where we used Y90 as a primary therapy. So we basically had phase 2 level evidence. And there's actually one French national registry where every single patient in France who received Y90 was followed, including patients with cholangiocarcinoma. That's called Proactive. That's going to be published shortly. But what we have seen is that you can use it very similar to what was described for external beam radiation therapy. We use it as an ablative modality. What does that mean? If I find a volume of liver that's expendable, I can intensify the treatment by raising the dose of both the number and the actual heat of each one of those little Y90 particles. And what we use to allocate external beam radiation therapy and Y90 is really based on what I mentioned earlier in my presentation, which is phenotypes. The fancy terms of just saying, how does this lesion look? Where does it present? What's its blood supply like? And again, I'm fortunate enough to work in a clinic where everyone's extremely collaborative, and we sort of see this as an energy therapeutics question, which is we have different ways of delivering this energy. Which one is best suited to optimize that patient's unique presentation? And so since we try to get so many people to resection, we will always say, well, gosh, I can treat this, but would you be willing to resect it if I were to remodel the liver accordingly? If someone is anatomically, in particularly unresected, because anatomy is favorable. So our surgeons and our tumor board very commonly say, can you treat this Y90 tumor with ablative intent? But as an extra initiative, can you start remodeling the liver? Because if they do really well, I showed you a case where we had complete response, but that still is not a replacement for surgery, in our opinion. We're still saying, can we still get them to that gold standard? So to answer your question, we have a lot of really good therapies, and I've always been a fan of saying, just because there's another therapy that's good, that doesn't mean that yours is bad. It means that it's time to get granular, time to get detailed, try to translate that nuanced experience into standards. And that really is capitalizing on unique opportunities and then making sure you have a team that collaborates well to make sure that the patient is offered those advantages.
100%. Going along the lines of Y90, let's say we have treated an individual with Y90. One of the scenarios I encountered in my practice is, I see a report from the radiologist, stating there is a response, but there are some residual cancer. But then commonly I talk to my 90 colleague, and they, actually state that, actually there is something different here. We would like to talk it and make sure. So when these scenarios happen, Alyssa, I want to get your thoughts on how do you handle those discrepancy, and how do you talk to the patient about what the response, and also tell us about when do you get a scan after Y90, and when is it appropriate, and your experience, please.
So a lot of the times for Y90, we're targeting multiple vessels, especially for cholangiocarcinoma. They're very hungry to get nutrients from the blood. So there's sometimes a lot of roads to go to the tumor. So depending on when we deliver the dose, like say if we are trying to downstage so that one of our surgical colleagues can resect this or get them to transplant, sometimes we can only see so many spots the tumor is taking up blood. And then sometimes afterwards, you know that there's a new spot that's either on the periphery that maybe we didn't see on our like mapping or planning stage as well. And now more blood flow is able to get to it because maybe like the analogy we used of 9 out of the 10 doors, maybe we took out the first 8, but not the 9th one. So on imaging, we as an institution usually get imaging from 1 to 3 month follow-up. The 1 month follow-up for Y90 is hit or miss, I think, for a lot of these patients. So a lot of them, I just usually am reassuring them. And then definitely at the 3 month mark is when I'm like, yes, the disease is being treated well, or no, it's not. And there is some confusion because I know all of our patients get access to the portal. So now with radiology, they've also brought up a thing called non-progression. So there's non-viable, which means we killed the tumor for sure. Non-progression, where it's like, we think everything's going well, but we're not positive. We can't fake this a slam dunk. And then we can say progression. So either there or there's viable disease, which just means there's tumor there. If it's within the tumor bed, then our radiation oncology usually can do a good job of then using radiation, external radiation to kill that tumor. If it's on the periphery or if we think it's a spot that we didn't treat before, that's when I'll go back in and map our plan to try to see if I can get to that tumor and use those radiation beads. Because we can do radiation to the tumor, we can do radiation to the tumor and to the side of the liver to make it bigger. Then we can also do, like I said, the portal vein embolization, which is not usually with radiations, it's with other particles to seal off those vessels so that part of the liver doesn't get bigger or get smaller so the other part gets bigger. Any other questions?
I have a question for you. So why do we not see radiation used earlier on in diagnosis in the first line setting more often? I feel like it's always, second line and further down, unless you're using it to hopefully get to surgery. But, in conjunction with standard of care and first line, I feel like it doesn't get combined a lot. Well,
You start.
Yeah.
I don't think there's a good answer for that. All I can quote is that the data suggests that for inoperable cholangiocarcinomas, radiation works. We have heard multiple presenters make the same statement: radiation does work. We need to use high dose radiation. You need to target it properly, and you need to make sure that you don't produce a lot of side effects. Now, is it feasible in all patients at all centers? The answer is no. For example, the interventional radiology experience that we saw today is not commonplace. It does not exist in all institutions, not even in big institutions, not even in all big institutions. So a lot of it depends on boils down to the expertise of individuals who perform this treatment and the technology that is available. But I think that's definitely a good option to consider for patients who are inoperable. And that's what the MD Anderson data did show.
I totally agree. I think that we need to think about how we view this condition, which is historically people always said, well, it tends to be a systemic condition. And that means we're gonna fight a boxing match with only opponents for systemic therapy. And that's great. It's a very powerful instrument. But what we see and what we learn about this is that it can evolve over time and you have different threats to you depending on where it is. And so what we have done more is start blending based off of what a patient needs. And that means sometimes protecting the liver function. So as you saw, radiation is really good at generating a response. What makes this cancer dangerous? It's the fact that it can mess with how your liver functions, which is an absolutely critical organ. It's like your heart. And you have to protect that. And we have not typically seen, as a matter of fact, you saw radiosensitizers. We have not seen them. These two therapies argue with each other, or both. And that's why we're doing clinical trials, like I mentioned earlier, specifically to follow this and what's the right recipe. But it's okay, in my opinion, to treat a disease that has a systemic risk with more local therapies as needed to just secure that front, to make sure that that area does not progress and cause mechanical harm. So I think our philosophy is changing, that we don't see this as being unicompartmental anymore, where it's just a systemic illness. No, please, all hands are even. We will deterrence this.
That's a great question, and I think that's part of our multidisciplinary discussion as well. I think Dr. Akshay would agree too. Is we're not seeing this as a patient who can only get Y90 or a radiation or a surgery, like a compartmentalized approach. Our discussions, of course, started with the clinical trials first, and then how can we combine them together? As Dr. Toskich mentioned in his talk, biology is key, and I think you know, the test of time gives us the right answers in terms of where we could take the patient to one step to the other. I know we have our patient talks lined up as well, which are great examples of, you know, how we have combined multimodalities. So more to come after the break, but please, question.
Thank you so much. Hi, I'm not awful, I'm a data scientist in all this, but I work on liver cancer in the past. So I think that, you know, hearing from you is very insightful, because it kind of also resonates with me from a different angle. So as a data scientist, what can we do? Because the patient itself, you know, the treatment, to me, mathematically is optimization problem. We needed to somehow give the best strategy to the patients to maximize their survival, quality of life, etc. Right? But we can only do this experiment, right? So a lot of trials, they're just using case and control. Your one strategy versus another strategy. It doesn't have a whole battery of strategies together to try out the patients. And so I think that the clinical trial knowledge of TENT is very crucial in some way. So you're talking about multimodality of treatment for the patients. I wonder what something that I can lead can help in terms of pushing forward criteria so that the patient get the best chance. Thank you.
I'll jump in. So I think early diagnosis actually is a huge area for data science. I mean, like, you know, we think of sort of classical risk factors, you know, liver fluid disease, cirrhosis, things that are very clear phenotype. You know, there are probably some combinations of factors out there in the population that we probably wouldn't even think of to put together in our heads that say, hey, this is a high risk patient for cholangiocarcinoma. So I think this is a great area for sort of combining like big data and machine learning, things like that, to recognize the signal there amongst all that noise of who in the population might actually be at extra risk that we should start a screening program. Because there's probably some connections out there in the wealth of data we have, kind of in, especially as you get large EHRs connected through Epic or other systems, claims data, things like that are very rich data sets with labs, history, anything like that, that can maybe make some connections that a human wouldn't otherwise think to make, to say, hey, this is someone you should screen. Because if you can find this disease early, you can cure it. That is the problem, like everyone said, is it's usually too late for a cure. Oftentimes, unfortunately, when the disease is found, and even making the diagnosis can be a challenge. I mean, we often do very, very big surgeries without even having the tissue diagnosis, just based on high suspicion, because it's very, very hard in some types of cholangiocarcinoma to get tissue. So I think if you were able to identify a population that should be screened, based on sort of big data analysis, that would be a game changer.
Basically, introduce myself. My name is Lara Kamar. I'm the vice chair of research from the Biomedical Informatics and Data Science Department, just on the coastal. So I'm already starting talking with some of the, you know, the issues here in the audience. I really would love to, you know, get into the team effort, really like make an impact on patients.
Appreciate that. And I think, and thanks for that plug-in too. So when you ask the question, please introduce yourself and what you do. We are here to collaborate. We're here to work together, right? Maybe last question, and in the interest of time, you know, this is to Dr. Sheikh. You know, you talked about liver transplant, Dr. Sheikh, and looking at the criteria, it looks little more stringent than for the liver cancer itself, for the cholangiocarcinoma. So two questions, I guess. One is, why is that so? And number two, and does that differ between within the liver, outside the liver in your thought process and the data? And number two, as we treat our patients, going back on Melinda's question, together with chemo, immuno, Y90 radiation approaches, when would you and what are the patient characteristics you like to see for them to take to the transplant? Hey, this is what the phenotype I like to take to the transplant.
So I think the reason that we are a little bit hesitant or have been hesitant with cholangio is because of the concern about it being a systemic illness, and then the fact that we have felt traditionally that it has a poor biology. So I think up until now, it has been difficult for us to delineate which patients are the ones that are going to have a good outcome after transplant, and which ones are the ones that we might accidentally hurt in that process. Because yes, you can get the whole liver out, but then when you put this new liver in and you throw in this whole bunch of immunosuppression to these patients, their bodies are going to respond very differently. They're not going to have any of the ability to kind of hold that cancer in way that may have spread elsewhere that we were not aware of. And I think that sort of comes historically from the results or the outcomes that we had very early on when we started doing transplant for HCC, which is primary liver cancer. Is that the thought was, okay, well, the liver disease is so advanced, you can't cut out part of it. Let's take out all of it and replace it with a liver. And those patients had a very poor outcome. So that put a great damper on the use of transplant for oncology and for cancer indication. And then it sort of progressed to where the Milan criteria came about. We had smaller cancers, we had early, we had treatment for cancers, and we slowly expanded the indications. I think now we have ventured into colorectal metastases and transplant for that, and we're venturing into cholangiocarcinoma. And I think we're starting small, but the hope is that it will expand and it will grow further. And with the advantage of the multidisciplinary treatments ahead of time, that will allow us to buy time and then see what the biology of the disease is in that in a particular patient. I'm hopeful that ultimately genetics will play a big part of it. We will be able to have more tumor markers that we can use to be able to decide which of these patients are going to benefit from transplant, which ones are not. Because really, ultimately, you don't want to hurt the patient in the process. So I think a little bit of our hesitation and fear comes from that. But I think collaborative efforts of this kind will be really helpful in further defining these indications and hopefully expanding them, I guess is what I'm getting at. As far as the patients for the second question, the ones that we want to take to transplant, is that the transplant is a big undertaking for the person. So you want to ensure that everything else in the process is also well controlled. So when we evaluate patients for a transplant, we sort of look at them head to toe. So you're looking at their heart, you're looking at their lungs, you're looking at their functional status. Is that the patient is going to get worse before they get better, and do they have that bandwidth to get worse before they're going to get better? So you want to make sure that, if they're kind of hanging off the cliff by one finger, you're going to knock them off if you try to transplant them. So what can we do to optimize them? What can we do to get them better before we put them through all of this and then ensure they have a good overall outcome? It's not, can we do the operation perhaps, but are they going to have a good outcome?
Great. Well, let's, one question, yes, please.
Start to ask this, I'm sorry. My name is Patty. My husband passed away, it's gonna be 8 years ago with cholangiocarcinoma. Back then, we didn't know, so I'm gonna ask this question. As you do the research, as you go through, are you thinking or seeing this cancer is more environmental? Or where are you kind of taking this?
I'll give you information from the process perspective. We had unfortunately seen it's two trends that we need to fight. First one is we're seeing this in younger and younger patients. As a heroin. The number of patients that I see that have children in elementary school is far too many. The second thing that we're seeing is that it is a surprise diagnosis too. Even with historical risk factors that were mentioned, we have to stop making this cancer a giant of us. Right? It absolutely has to stop sneaking up on us. So when we look at this therapy, and we look at, okay, what can we do to people earlier look at screening, we look at why is this happening? We suddenly delve into a bigger question that I think comes in to the answer, which is we're seeing an increase in all cancers in younger patients. I mentioned transplant or colorectal cancer, so we just transplanted our 22nd patient for colon cancer. And that's a good majority of them under the age of 50, and there's far too many that are under the age of 40. So I think there's something going on that is likely multifactorial. And I think what happens is your body's really good at fixing cancer. It can find a cancer, and there's so many mechanisms in place to repair a stumble in your DNA, where had it not been corrected, it would have manifested as a cell that doesn't listen to you. I think that what's happening is there's probably too many things that are causing those stumbles, which is the environmental thing given. But I think our ability to repair may be affected. And I think that comes into such a difficult thing. And I would actually welcome, I'm gonna ask questions to the audience. I would welcome a bioinformatics colleague. Hello. I would welcome your thoughts on how can you start answering this question, given how multifactorial this could be.
Yes, how can we first question? So, I think we may need collaboration. So I'm not a data scientist. I think, another example that we see in liver cancer, if you market scan from the US University scan, which has 260 million patients, we know the whole pancreatic cancer is a huge regional disparities. It's different from, states to states in the US. And I think that definitely is a sign of environmental, issue. And so, based on both types of cancers, like GI cancers, so I suspect that there's also probably the environmental issues. I can put the answer to you will definitely be my second students, so looking at the data set, the macro scan data set. But I do think that lifestyle plays a big role, right? What you eat, it affects your guts and affects your liver. Liver is where you store energy, turn glucose into glycogen, etc. And metabolites, and then you use drugs. Those things are all affect the liver functions. And I also think that the environmental where you live, the air quality, all of those things. I think it's really we need to look into that. However, it's not easy. It is not easy because you're turning out. You're turning out probably okay. You can look at patients' zip code and the geotagging, link with CDC data, etc. Look at the environmental data from other government agencies. I think there's a way to do it, which is we need to get different types of data all coordinated together, do the investigation very individually. Does that answer your question? I don't know the exact answer, but I think it's a good research environment that I also are interested. I would be interested. Thank you.
All right, we have time for one last question. And there's a lot of interest. That's phenomenal. We're a few minutes over time, but
My name is Heidi Ray. I'm a 15-year survivor this year. I started a nonprofit called Rainbow after attending my first conference. I was a 7-year survivor when I finally met the first person with this cancer. Now, I'm mentoring, I live 30 minutes north of New Orleans. I'm mentoring 5 patients in my town. And I'm constantly being asked, why is the number going up so high? The doctors have said they've never seen so many bile duct cancer patients. I know there's an area not too far that they call Cancer Alley in Louisiana. We have a history of drinking, cirrhosis of the liver, obesity and stuff. Are we diagnosing more people? What can I answer when they say why is the number increasing? And environmental, I know in the food, can you give me a good 1-sentence thing that says that might help me answer this? No. Okay.
I think historically,
You're gonna help?
yeah, definitely we need to know a lot more about why it is happening and why it is happening at an early age. But a lot of the times in the past 2 decades or even longer, cholangiocarcinoma has been identified as carcinoma of unknown primary. We have about 20%, at least in the past, that were detected of carcinoma unknown primary. And if you go back and we're doing some work and we're submitting some papers, data to the annual symposium in Utah, and we identify that a good proportion of those unknown primary cancers turn out to be cholangiocarcinoma. Is that because we're able to detect them better now? Is that because of our staining patterns are better, our images are better? There are a lot more factors to it. Or we also have comprehensive genomic sequencing, and some of them are in the room here today with us, the industry, that are able to detect at the granular level what type this could be with 80 to 90% success, right? I mean, that is not 100%, but I think we were way beyond back 2 decades ago. So that's at least one part of the answer to it, but there's a lot more to it, but I can think of anything you want to add from the group.
One of the issues we have is the injuries to your DNA that can lead to this can take decades to manifest. So when you are doing something that seems like it's fun, and you're doing it 2 decades plus, when you realize that there's an issue. And then at that point in time, there's other things that have happened to you in your life that out of the picture, but you're taking a real broad step back. We don't have the exact science for cholangiocarcinoma in particular, but what we do know is that even certain societal trends like raise your hand if you were in the mid-90s and you ate a fat-free salad dressing, you thought that was the right thing to do. Turned out it was the wrong thing to do, right? Your body is way better at processing fat than it is at processing high volumes of sugar. And what we saw was, as a society, we paid the consequence for that poor understanding of what's the right thing to do in the form of a lot of metabolic liver disease. And now we know that when you have that condition, which is your liver is not processing things well that you digest, that leads to inflammation. It's probably having olive oil is way better than having fat-free. And I bring it up because chronic inflammation in the liver can lead to all the things we discussed today. But even things like non-stick coating, now there's now an association with non-stick coating on pans, little tiny microscopic bits of that shed off, eat it, and it actually ends up in the liver and cause inflammation. Right? So what seemed to be a great advantage that is used on a daily basis to make your breakfast. Suddenly we learned, gosh, maybe that wasn't such a good idea. But it took 30 years for us to figure it out. And then I think that's the hardest part about this, that it takes such a long time. And then what you think is doing the right thing for your health sometimes isn't. And it's a struggle.
Rosie, were you commenting on this?
I was going to mention roughly the same thing. There are a lot of metabolics, metabolic syndrome, so to speak, which has an influence in the development of these cancers, which we are slowly learning about, especially in the recent years. We know for sure that the incidence of NASH cirrhosis, for example, is increasing in the West. So we know that is one of the causes for cholangiocarcinoma. So that could be one of the contributing factors. But what contributes to the cirrhosis, is it just NASH or are there other metabolic syndromes which contribute to that? We don't know. That's something probably learn as time passes.
Yeah, a lot more opportunities there for research. But let's take that as our last question there, and then take a break. So thanks so much for the enthusiasm and the questions. Let's keep them coming. Are we gonna? Yeah. So slight change in the agenda. So the lunch is here already. So if you can go grab lunch, probably in the next 15 minutes, and have you seated, we will start with our next session. So please stay tuned. I think this is going to be the most exciting session coming up.
Stop trying to guess. Yeah.
Yeah, I believe that actually.
Go and get started with the post lunch slash break session. And I think this, now we come to the most important part of today, right? Like why we do what we do. Hearing directly from someone who lived this journey, and that's being shared by our beloved Fred Newbar, who has been fighting cholangiocarcinoma, still fighting this. It's truly an honor to have him, a patient and a survivor whose strength, resilience, and courage inspires us all. Behind every diagnosis is a person, family, a story. And today, I think we have the privilege to listening to a couple of those stories. As physicians, we talk about treatments and the scans and outcomes, but patients actually do teach us what those really mean, right? So I would like to, have Fred over here and really thank him for being here despite his busy schedule. So let's invite Fred to the podium.
I'm having a hard time hearing. Can you hear me okay?
Yeah.
Thank you, Dr. Mala, for letting me speak today. And I want to introduce some folks that are near and dear to my heart that are cholangio warriors. As he mentioned, I've been fighting this disease now for 6.5 years. Had a multitude of different treatments. I'm fortunate to be FGFR2 positive, and I've been on an array of 3 drugs that have kept my quality of life quite well. I want to introduce one of our first speakers, who's Aaron Drake. He's 32 years old, here in Birmingham, Alabama. His treatment journey so far has included chemotherapy, immunotherapy, and recently a resection. And he lives day in, day out with his greatest source of strength, his wife, Sade, and I just met his beautiful young daughter, Honora, who check out her T-shirt she's wearing after his speech. She's got a Cholangio Warrior T-shirt on, which is great. So with ado, Aaron, come on up and tell us your story.
Hey there. Sorry, I'm not really one for public speaking. But yeah, excuse me. As I'd just like to start by introducing myself. As I said, my name is Aaron Drake, 32 years old. I have a beautiful wife and daughter, and in October of 2022, I was diagnosed with cholangiocarcinoma. The last few years have been rough, to say the least. And I just like to take this time to share a bit of my journey with you and let you know that this disease has changed my life. Late 2022 is when I'd say I noticed something going on that I wasn't exactly sure. I was having constant stomach pains, wasn't sure what was causing it. At this point, it wasn't too bad, so I'd take a couple of ibuprofen. That would knock out the pain for a few hours, and I continue about my day like nothing else really mattered. It wasn't that I was worried about the diagnosis or anything like that. It was more so just didn't have the time to have it looked at. And that was a mistake on my part. I started a new job a few months before, and my wife and I were actually house hunting in our downtime because we just sold our home and was looking for somewhere with more space to build a family. And it was around that time that we actually figured out that we were pregnant. And we found out not too long after telling that they were gonna have a baby. But with all this going on, I decided that I was gonna put a pin in whatever was going on with me and focus on what was going on around me. Around February of 2023, when I decided to get everything checked out, I went to a different local hospital and got to let them know what I was experiencing. They decided that they wanted to do a colonoscopy and told me that it could also just be heartburn. That wasn't quite what we had going on. We would later figure out, but it was all adjourned. As expected, the colonoscopy was ineffective in figuring out what was going on, but the ibuprofen was still working, so that was all I needed for the time being. It continued like that for months. In July 23, that's when we had our beautiful daughter. And it's like the world stopped. She was all that really mattered, and the world revolved around her. And it wasn't until October that year that I decided that the pain was just too much at that point, and I wanted to get it checked out. I came up here to UAB, went to the emergency room, and they did an ultrasound and found a 13-centimeter mass on my liver. It had grown a lot since that point. I found myself wishing I had gone sooner. My family was always pushing me to get out there and get checked out, but as I said, family came first, and that was what was important to me at the time. What makes it worse is I went into the ER thinking pancreatitis was probably the worst case, and I found out that worst case was much worse. When I got my diagnosis, my mind was racing. All I could do was hold my wife and tell her I love her and imagine worst case scenarios. At one point, after they told me, I even just asked the doctor treating me about how long they think I had with a cancer diagnosis. I didn't even know what kind of cancer it was at the time. They admitted me immediately into the hospital. I'm grateful for the fast action because it definitely could have been what saved my life. Around this time, getting out of the hospital from that day, when I met Dr. Mala, my oncology team. It's been an invaluable resource, and I truly appreciate everything done for me. I started testing. We have multiple biopsies, at least 4, I want to say. They had to keep doing them because every time they get a sample, it's too much necrotic tissue and didn't tell who we were working with. After that 4th biopsy and getting enough viable cells, they were able to say, hey, yes, this is cholangiocarcinoma, and we have a plan going forward that we want to take. At this point, I would have done anything. We had a young girl, I've only been with my wife for 5 years at that point. I wanted to spend as much time with my family as possible. It broke my heart to have to imagine the future that they would have to go on without me. And in late December is when I started taking a turn for the worse. I was jaundiced. I was constantly tired and the pain in my stomach had come back and it's just as bad as it was in the beginning. Of course, I went up to the doctor. They hospitalized me, ran some tests, and found that my bilirubin, which normally is between like a 0.5 to a 1, had spiked up to a 9 due to a blockage right there because of the mass. They placed a stent that helped with the blockage, brought my bilirubin down, but it wasn't going to help with the issue of the mass. So that December, on Christmas Day, we started chemo. Aside from the exhaustion from chemo, I didn't see too many side effects. There was a bit of nausea. Luckily, I was able to keep my hair. That was a big thing for me. I returned to work, need to try to live my life as normally as possible. Once a month, I'll plug in maybe for infusion, have my chemotherapy, my immunotherapy, and have my family help out whenever I needed. They were always there with a helping hand, whether it was to help me after chemo, giving whatever I needed, watching my daughter for us, while my wife helped me with everything I needed. We went down to Florida, went to the Mayo Clinic, MD Anderson, just to get second opinions, see if maybe they had a different path they wanted to take and let us know that this was going to be the best path moving forward. Chemotherapy, immunotherapy, and just keep on, see what happened. So for the next few months until July of 2024, we'll keep on chemo, going through the cycle, work, family life, infusions, and kept on that for a while. And then a few days after my daughter's first birthday, we would stop the chemotherapy and just do immunotherapy with the hopes that with everything that we've done to this point, the mass would shrink in size and we'd be able to do something about it eventually. And luckily it did. It continued shrinking from the original 13 centimeters. It was down to about 10 at that point. And with continued treatment, we continued to shrink and got down to about 8 centimeters. And from July to February, we continued on immunotherapy. And the mass continued shrinking. We were lucky, blessed, and just thankful that everything was working out the way that we had hoped. That would change is they noticed some of my liver enzyme numbers were trending upwards, so we had to stop immunotherapy as well. They noticed some nodules in the lungs that were likely caused by the side effects of lidocarimab, and we didn't want to take any risks. At that point, there was nothing to do but wait and hope. And that's what we did. I held my wife's hand, came up here to the doctor's office to see Dr. Mala once a month, and he let us know how we were doing. And luckily, it went well. The mass shrunk down from 8 centimeters to 6 centimeters. And Dr. Mala let us know that there was a chance that we could take out the tumor completely and hopefully move forward. Ecstatic to say in June, just last year, they cut out the tumor, most part of my liver, and bile duct, and been cancer-free since. This journey is the hardest thing that I could have ever imagined. And I cannot emphasize enough how lost I would have been without the support system I had around me. And I am eternally grateful to everyone that extended a helping hand in this crisis that we were going through. And as we move forward and try to continue to recover physically, emotionally, financially, I'd just like to be here and extend a hand to anyone like me who may be in need and going through something like I went through. I'd like to thank you all for listening. Truly appreciate all your time today. Thank you.
Well spoken from the heart. Our next guest is Gonzalez Concepcion. She was diagnosed at age 40 with a large cholangiocarcinoma tumor in her liver. From the very beginning, she's faced her diagnosis with strength and is a true warrior determination. A true fighter, she never misses an appointment and meets every challenge head on, no matter how difficult the road may be. She draws tremendous strength from her family, especially her son, Jesus, who will be her interpreter today. Through it all, Gonzalez continues to show resilience and courage and unshakable commitment to never give up.
Hola, mi nombre es Concepción González.
Hi everyone, her name is Concepcion Gonzalez.
Yo fui diagnosticada con cáncer
She was diagnosed with cancer
en el 2024.
in 2024. Can you hear her?
You want to access the paper? It's right there on the podium.
Oh, clicker.
Okay. ¿Cómo empezó?
Yeah, perfect.
So how it started?
Todo empezó con un dolor de estómago
Everything started with a stomach pain
que iba desde la espalda, desde la panza hasta la espalda.
that would go from my stomach all the way through my back.
Sentí una pequeña bolita
She felt like a mass
en el estómago que obvio no era normal.
in her stomach, which obviously was not normal.
¿Cómo nos enteramos de esto?
How do you find out?
El dolor era intenso. Tuvimos que acudir a emergencias.
The pain was really intense and we had to go to the emergency room.
Me hicieron varios estudios de exámenes y una tomografía.
They did a lot of exams and drum blood and a CT scan.
Y de ahí me dijeron el diagnóstico.
And that's what they told her the diagnosis. That time they told us that cancer could have been a possibility, that it wasn't for sure, and to get tested somewhere else to make sure it's actually cancer.
¿Cómo mi familia se tomó esta noticia?
So how did my family take this news?
Mi familia, obviamente, como todas, creían que no era real.
My family as well as other families could not believe it.
Solo se preguntaban que por qué yo.
They were just wondering why her.
Nosotros estábamos muy tristes por esta situación.
We were all very sad about this situation.
¿Cómo nos enteramos de UAV?
How did we find out about UAP?
Después del diagnóstico de emergencias, nos dijeron que necesitábamos contactar a mi médico primario.
So after that diagnosis in the emergency room, the person at the ER told us, it would be best to advise her, primary physician.
Ellos inmediatamente me refirieron a UAV para que yo recibiera el mejor tratamiento.
And her physician, immediately, referred or recommended UAB to try to, get the best treatment.
Mi proceso en UAV.
My process in UAB.
Mi doctora principal inmediatamente me mandó a mi trabajadora social.
Her primary, primary physician, her primary doctor at UAB sent her, a social worker, for her insurance.
Para procesar mi aseguranza y me hizo mi primer cita en UAB.
To process, insurance and so she can get her first appointment in UAB.
Mi primer cita en UAB.
My first appointment in UAB.
Aquí fue cuando me confirmaron mi diagnóstico.
This is where they confirmed that I had, I'm not sure how to pronounce. the name. Yes, that, yes. Or, the cancer.
Y me asignaron un oncólogo.
And they assigned her an oncologist.
Mi oncólogo me dio la bienvenida,
Her oncologist, welcomed her.
me explicó el tratamiento y buscó la mejor opción para tener una mejor calidad de vida.
He, explained her the treatment and looked for best options, to improve her, quality of life. And, you can see here, the picture that's, it was, what is that? 10 centimeter? Yeah, 10 centimeter by 6.5. You can see right there.
Mi primer oncólogo oficial.
So her first, actual oncologist was Dr. Kyle Cameron, which he, unfortunately moved states to go somewhere else, yeah.
Él solo se encargó de que yo tuviera una mente siempre positiva.
He was always sure to give her a positive mindset.
Él era el que me daba los resultados del laboratorio y me explicaba cómo iba yo en mi proceso.
Just like our current, oncologist, he was the one in charge to give her the lab results, explain her, how her process was going.
Mi primer tratamiento.
My first treatment,
El primer tratamiento, como todas las personas, pues yo estaba muy asustada.
my first treatment, like everyone else, I was very scared.
Para esto fue muy reconfortante tener durante mi primer tratamiento a mis amigas, mi esposo y el único hermano que tengo aquí en Estados Unidos.
But it was very comforting to me, that throughout my first treatments, I had my friends, my husband, my brother, and me, my sister, comforting her.
Me siento cansada,
On her first treatment, she felt very tired.
a diferencia de hace 2 años y 3 meses que tengo de recibir tratamiento.
Sorry, I got that mixed up. She didn't feel as tired as now after 2 years of treatment.
Después de 6 meses, mi oncólogo se fue y me asignaron a mi doctor Mara.
After her 6 months, Dr. Powell moved states and they assigned her Dr. Mara.
¿Cómo empezó mi tratamiento nuevo?
How was her new treatment?
Con la llegada del doctor Mala, llegaron nuevos tratamientos y propuestas por él mismo.
With the arrival of Dr. Mala came, new treatments, different, treatment proposed by him.
También llegaron nuevos doctores a mi vida como el radiólogo.
And it also came along, the radiologist, Dr. Krishnasamy. He's not present here today, but
Después de 6 meses de tratamiento, nos enseñó empezamos con las quimioterapias,
After 6 months,
continuamos con las quimioterapias,
we continued with the chemotherapies.
después las descontinuamos y seguimos con la inmunoterapia.
They discontinued chemotherapies and they continued with immunotherapy
Que el mismo doctor nos propuso.
that Dr. Mal proposed.
El tratamiento Y90.
And then after that came the treatment, after not seeing such a good response from the immunotherapy, came the treatment 190.
El doctor Mala y el doctor Krishnan se reunieron para detallar el tratamiento de Y90.
Dr. Mal and Dr. Krishnasamy came together to discuss about the 190 treatment.
Que sería mi primera radioembolización.
That would be her first radioembolization.
Fue uno de los tratamientos más dolorosos, fue muy difícil y lenta la recuperación.
So that was the most painful treatment so far, and the recovery was very slow and very difficult for her.
Los síntomas.
Symptoms.
Siento que muchas personas saben los síntomas que esto conlleva.
Pretty sure anyone who has had the 190 treatment know what kind of symptoms it goes through.
Es náusea, vómito, constipación, dolor de estómago, dolor de hígado.
So a lot of internal burning, that's for sure. A lot of nausea, vomiting, constipation, and being too tired as well as a lot of liver pain.
Después de la Y90 recibí más quimioterapias.
So after the 190, she received more chemotherapies,
Una quimioembolización
a chemo embolization,
y otra Y90.
and another 190.
Recibí muy buena ayuda del equipo de radiología, también del equipo del doctor Mala.
I received a lot of help from interventional radiology as well as Dr. Madison.
Estamos muy agradecidos por su ayuda emocional que nos dio el radiólogo Krishnasamy.
We are very grateful for all the emotional support and help that radiologist Krishnasamy gave us through the process.
Hasta el día de hoy continúo con mis quimioterapias. Dentro de un mes tendré un PET para saber cómo vamos.
Okay, so to this day we continue with the chemotherapy treatments. In a month we will have a PET scan to see the results of the last 190 she received. And thank you, Dr. Mal.
Thank you.
Dr. Krishnasamy, because he's not here, and to all the DAP support team.
Thank you.
I guess we're into questions and answers. Anybody have any questions?
Okay. We will ask questions. I can start. I mean, those are my patients, and I really I'm really grateful to see you, the courage that you have shown to come and speak. I know I think I pushed you a little bit, but still, it's not easy to like stand up and speak and be inspiration for all of us. So thank you for doing that. Starting with Drake, one thing that reminded me of when we started almost 2.5 years ago. Your beautiful wife used to come together. I know you were expecting a baby at that point. Initially, she was with you with every visit, and eventually, I think she was stopping coming on visits. That's when I felt like she felt reassured with me and with the care, everything that but I can understand, right? I mean, as the process goes, initially, what you're been through, what the importance you give to the family than yourself, 32-year-old, a 30-year-old, even when you're diagnosed, if you have a symptom of pain, we try to brush it aside and say, no, what family comes first. But do you want to tell us more about like your experiences at that point, like balancing your care versus the family care? Yeah.
Yeah, it's all just a balance. I would have my treatments, wear me out, but I knew what I needed to do for my kidney. I wasn't gonna just sit around and not take care of my body with my machines. I wanted to do everything I could do. I didn't know how long I would be able to at that point. So honestly, I may have pushed myself a little hard than I may have should have, but it was all worth it in the end. All just the balance. Just have to figure it out.
I just want to thank you both for sharing your story and for the courage to get up and tell it in front of all of us. We appreciate it so much and it's going to help so many others. I also want to just let you know that we have support for you at the Cholangiocarcinoma Foundation. Again, the build support group that maybe you could jump on and maybe share your story there and help others. And we also have a Spanish speaking support group too. So I think there's ways that if you feel brave enough and would like to share again, it would be awesome.
Yeah, I would love to.
This is a 16-year survivor of stage 4 cholangiocarcinoma. Yeah, over there is a 15-year survivor. Back here is a 5-year survivor. So there's lots of long-term survivors here.
Lots of hope.
Lots of hope.
Gracias por compartir tu historia. ¿Cómo recibir tratamiento de algo tan serio como es el cáncer en otro idioma, en otro país? Si puedes decir algo. So I just asked her, what's it like receiving cancer treatment for something so serious in another language, in another place?
Great question.
Bueno, siento que no es tan difícil cuando tienes el apoyo del bar.
Well, thank you. I feel like it's not too hard or difficult when you have the right, kind of help.
Cuando te encuentras una persona cálida que te da la confianza, aunque no sea tu idioma, sientes esa confianza con la persona que te está tratando.
You just feel the quality with, person is treating you feel the quality, you feel how they are, and you just feel well trusted with them.
Thank you. One thing I want to plug in is Eric's story. We had to go through, for a 13-centimeter mass, 4 biopsies to be able to get an adenocarcinoma diagnosis. There was suspicion, but not enough for us to call it cholangio because of pathologists who are able to conclude it. And also, we understand how important it is of getting the tissue to do more gene sequencing. And we used blood sequencing for him, and he was found out to be MSI high. So that's not a common thing to have for cholangio, but thankful to our efforts and Mayo Clinic efforts together, we were able to identify that operation and we're seeing significant results for healing. And then regarding Gonzalez, I think she has already highlighted it. Every time I see her in my clinic, I think of her as a warrior in a battlefield, right? I mean, she has been seeing so many lows after these treatments, the side effects, and it's been 2 years, she's still on frontline therapy, I don't want to lose it, but still fighting hard in the process. So I think inspires all of us, every patient that we treat in the clinic has a story that needs to be heard, but I just wanted to add those as well. Any final comments from both of you that you want us to know about the story?
Bueno, lo único que les quiero comentar, hay muchas personas que ya pasaron por este proceso, pero siento yo que la familia tiene un papel muy importante.
The only thing I want to comment is that I know a lot of you have went through this stuff. The family has plays a big role in this journey.
Y lo único que me queda decirles es que el cáncer no es muerte. Y hay que vivir un día a la vez.
I just have to say that cancer isn't always dead. You just have to live one day at a time.
I have, this is Mehmet Akçe, medical oncologist. I had a question for Drake, Mr. Drake. So we kept talking about the importance of multidisciplinary care. We really value it so much, and we make sure that we communicate with our colleagues to take care of patients who need multiple different physicians to be involved. Could you elaborate on your experience as a patient, how you saw the value of the multidisciplinary care? Multiple doctors are involved in your care, from medical oncology, surgical, and other disciplines. Could you shed some light?
Honestly, the medical team I've had has been Dr. King, who performed the surgery, Dr. Lawman, it's just disease doctors and taking care of me since the surgery as well. There's been a lot of times, yeah, forgotten some names, but each doctor in their own right, I trust that they know what they're doing and what it's like to do best for me. So it's honestly, it's all about trusting and believing in the system you have around you. And having one of the best, grateful each and every one of them that I'm able to be here.
Fred, do you want to share any of your experiences? I mean, you're one of our role models here, currently going through our treatments, and you, if you also tell us the balance between the care in Alabama and like the state and the care, and how do you like even find that balance and find the trials and treatment options?
Yeah, let me explain my situation. I live in Mobile, Alabama. My main oncologist though is at MD Anderson, and my oncologist at the University of South Alabama Mitchell Cancer Center. They're in collaboration. They keep in contact. Multidisciplinary at MD Anderson. Obviously, they have a great team there. I've gone through an array of treatments starting off 6 years ago with just GemCis is the standard of care initially. I've gone through SBRT radiation. My tumor, my largest tumor was 18 by 7 by 8 centimeters, very large, along with 3 tumors that were the size of Tyler's golf balls. I like to use the visual. And so I had SBRT. I was diagnosed at Mitchell Cancer Center's having an FGFR2 mutation. After chemo ran its course, I went to Pemazyre for 2 years, stable, but no shrinkage. Was on Futibatinib for 2.5 years and had about 35% tumor reduction. And the team thought it best to take an aggressive approach to my liver cancer. I also have it in my L3 and L4 vertebrae, hip, and in my lungs. I had microwave ablation therapy on the tumors in my liver. I had proton beam therapy. I've run the gamut of everything with Y90, I guess, is my last option for radiation. But I was on a clinical trial with the MUC1 at MD Anderson, lasted 2 months and they kicked me out because it just didn't work. And that's a clinical trial where you basically have a carrier drug that is your Uber driver to get the chemo to the MUC1 protein on the surface of the tumor. And it didn't work, but every door, every challenge has a new door to open. And currently I'm on compassionate care with tintigatinib, which is another FGFR2. And just got a recent scan a little over a month and a half ago. And in 2 months' time, going on to that drug, I had 30 to 40% tumor size reduction, which says a lot for just the 6.5 years that I've been at this, fighting this, as we all are. Tremendous gains have been made in the treatment of this cancer. And I'm hoping this is usually an old person's cancer. It's not, I feel for the but there's hope, and you just gotta keep fighting.
Great. So once again, thanks so much for joining in, and we will resume about 1:05 p.m. What time is it now? 3:45. Yeah, perfect. Yeah, about 1 p.m. Resume school. Okay, after Subhaya. So, all right, everybody. I know we're at 1. We would like to go ahead and get started. So, as you grab your drinks and get seated, we would like to go ahead and get started. I'd like to invite Stacy to who's going to chair the next session to take it over.
Right, good afternoon. Thank you, and we're pleased to welcome Dr. Ishwara Savaya, Executive Director of Cancer Care Equity and Professional Wellness at Sarah Cannon Research Institute, and Medical Director of Supportive Care Oncology, Health Equity, and Professional Wellbeing at the U.S. Oncology Network. That is a mouthful. Her work focuses on improving equitable access to cancer care while supporting the well-being of both patients and oncology professionals. We're excited to hear from her, so we'll turn the time over.
Okay, perfect. Let's see. And where's the little? I like that laser pointer, so let's try and see if I can get that on. Joy, perfect. Hi, everybody. Such a pleasure to be here. I get the after lunch slot. So this is when we were in kindergarten, we were rightfully napping. That's as our body wants to do very naturally at this time of the day. And so I'm going to do my best to cover integrative medicine in the context of biliary tract cancers. We're really going to focus on a few key pearls. And I want to assure you that some of these slides are extremely heavy with text, because I would like for them to be as a reference to you, something you can look back to if you wanted to dig deeper into any one component. But what I hope we walk away with from here is have greater clarity on the place for integrative approaches as part of your cancer treatment journey, or as part of a person's cancer treatment journey. And wherever we can find data that's specific to BTC, I put it in here. But a lot of as with a lot of things related to BTC, we really need to better understand the unique needs of persons and families who are going through a biliary tract cancers specifically. When we think of integrative therapies, we'll define what they are in a minute, but we have to understand that the horse is out of the barn, the worms are out of the can, the cat is out of the, or whatever other animal metaphors you can think of. Our patients, the people in our community, their families, they are far ahead of the healthcare system when it comes to looking at integrative therapies, those non-pharmacologic approaches to help with their cancer treatment journey. What we're also seeing is that major cancer centers actually do have integrative medicine programs at varying levels of maturity. But the place for integrative oncology as part of high quality cancer care is firmly established. There are some very encouraging statistics that show why there is a place for integrative oncology as part of the cancer treatment experience. And just as one example is acupressure for the use of symptoms in overall symptoms in GI cancer patients. So we'll talk about that in just a minute too. And so you won't today, in this day and age, you will not be alone in bringing up integrative oncology as part of your conversation with your healthcare team. And you will actually have more evidence, more clinical trials to back up the use of certain integrative approaches as part of cancer care. Integrative oncology is a field of medicine. It's a subspecialty of medicine. No different than oncology, no different than cardiology. Integrative medicine as a whole is about combining evidence-based approaches together with conventional cancer treatment to help treat the whole person symptom burden. And so this can be anything from physical symptoms you can't see, social health, sense of community, and the spiritual needs. These are dimensions that we already know from the data that they affect cancer outcomes. Imagine hearing that people with a less than ideal support structure, whether it's their own family or a sense of community, have inferior outcomes from their cancer treatment, whether it's time on treatment, whether it's the severity of the side effects they get. And so when we're talking about treating the whole person, I want to make sure one of my key goals for today is to take that narrative from the soft place that it may be, treating the whole person, and actually move it over to science. When you have evidence that the whole person dimensions directly affect cancer outcomes, suddenly it's not about the warm and fuzzies. It's about how do we make sure when we're taking care of someone that we do take care of the whole person. The next key core principle is evidence-based practice. This is a space that is highly lucrative in the general world out there. Billions of dollars are spent every year just on supplements. And so when we're talking about integrative oncology as a science in the context of high quality cancer care, we're talking about where there's the rigorous evidence and where we're all working together to generate more evidence. This is the third core principle is one that's really, really important to emphasize, but it's also one that may change. Today, based on the evidence we have now, integrative therapies are there to complement conventional standard of care Western approaches. They're there to support the patient and their families with side effects and other elements that are affected by conventional cancer treatments. We don't have the evidence today that an integrative approach, whether it's a particular herbal supplement or a combination of them, can actually replace cancer treatments, i.e. alternative to cancer treatments. So that's the big difference between complementary medicine and alternative medicine. So what you'll hear me talk about a lot is where the evidence is there. Now, if there is a high quality trial that comes out and says cocktail X of herbal supplements is just as good, if not better, as a conventional Western treatment, my mind is open. I will read that study. I'll look to understand it and see, is it something I would want to do? We're just not there right now with the evidence. And so what are we talking about when we're looking at integrative therapies? There are general buckets of approaches. The first category are those mind-body therapies, mindfulness-based stress reduction, anything related to mindfulness. Yoga, Tai Chi, meditation, cognitive behavioral therapy, hypnosis, music therapy. These all fall under the category of mind-body treatments. And then there are physical modalities, acupuncture, massage therapy, exercise, guided exercise program, acupressure, anything that's where you actually are physically doing something on to a person or a person's doing to themselves. And then finally are the herbal dimension, the nutrition and herbal dimension. And this is a critical conversation, and I'm so happy that Sharita is here to talk about this right after I wrap up. So let's do a quick overview of where the evidence is and what that means for by each of the three types of integrative therapies. We have solid evidence for mindfulness-based approaches for the management of anxiety, depression, and overall emotional well-being in persons with cancer. And so what we see are a meditation program, or mindfulness-based meditation program is actually strongly recommended under NCCN guidelines. Many of the guidelines that are the highest quality are the ones that are done with our Oncology Society, ASCO, in partnership with SIO, the Society for Integrative Oncology. And so if you're searching for what to do about any particular symptoms, remember that ASCO, ASCO acronym, and then SIO, the Society for Integrative Oncology, as key resources. There's strong data to support the role for a meditation program in reducing anxiety, treatment, and stress, and the benefits. This was shown across multiple studies. The benefits lasted more than 3 months after the study was completed. Everybody feels really good right after they finish something that's good for themselves, myself included. But what is important to understand is there an enduring impact? Are we able to really change our approach for at least the near to mid and long term? And so when the benefits are seen beyond even 3 months after a guided program is finished, you're getting hints that, okay, maybe there is integration of some of these practices, mindfulness-based practices, into day-to-day life. Yoga has multiple clinical trials to help with the management of anxiety, depression, fatigue, and overall quality of life. These trials were done with yoga therapy programs during cancer treatment, as well as after. And universally, what you see are patients who receive standard of care management for their emotional health, which can be one of many medications, plus or minus therapy. When they do the comparison to the standard of care plus a guided yoga therapy program, the group that gets the guided yoga therapy program has greater reduction in their key markers, markers of anxiety, depression, improvement in fatigue, as well as their self-reported quality of life. So when I talk about clinical trials in the context of an integrative approach, it may seem very familiar in its structure to really how you've seen your cancer treatment trials out there. What's currently being done, what's the standard, and then what's the standard plus the add-on. When we're talking about mind-body-based therapies, it's important to recognize that the 5 that you see here actually are part of the ASCO-SIO guidelines for anxiety. And so when we're looking at how do we, what can we filter down to as key recommendations that we would share with our patients in a healthcare setting, or our peers if we're crossing paths with someone going through BTC or frankly any cancer. Here are 5 evidence-based approaches that have an impact on the emotional health and well-being. Next, let's talk a little bit about the overview of the physical therapies. These are your acupunctures, your massage, your exercise, and more. Where do we see the strongest evidence for these physical therapies in symptom management? Acupuncture and acupressure have solid evidence for reduction of nausea and vomiting during chemotherapy. Reduction in both in the number of episodes, number of times a person feels nausea, as well as the severity, the intensity of the nausea. There's also high quality evidence for acupuncture in cancer-related pain and pain from damaged nerves, your peripheral neuropathies. When we're looking at exercise and movement, the strongest the strongest evidence for it, and the highest tier of evidence for it is in cancer-related fatigue. And we're going to dive into fatigue in just a minute as an example of how working with integrative oncology can be. This is defined as, could be walking, it could be swimming, it could be light resistance. They are actually all beneficial in the context of cancer-related fatigue. Massage therapy has been shown in multiple trials to reduce pain, total pain, as well as anxiety, depression, and can improve sleep health as well. Bright light therapies, just another example, where having a morning exposure to light for 30 to 40 minutes actually can help reduce fatigue measurably. This may seem, you may raise an eyebrow or semi-roll half an eye. Light, the impact of light on our mood and performance has been studied for years in the organizational psychology literature. The scientists and researchers who study workplace cultures, as well as folks who are in architecture and design. The art of ensuring you have, you're seeing indirect light, like this is perfect, right? Because what you don't want is direct light. That's where you start worrying about the cons of it. But this type of indirect natural light exposure has been studied as a science in multiple industries, and it's finally making its way into healthcare and into cancer care. The same reason why the newest buildings have very meticulously placed windows is the same reason we want to make sure everybody gets light in the morning to measurably reduce the fatigue. Next, we'll talk a little, I'll give you the overview of nutrition and supplements. This is like a multi-day conversation. There's a part of me that wishes I could go through key supplements. I'll leave some information here, and I'm happy to send some general info out after on what the overarching approach could be. There's absolutely nothing that can replace the guidance and the ongoing partnership with a registered dietitian. In the moment, as well as your cancer journey goes, the needs change, and they change dramatically. And so when we're talking about how do we find a place for nutrition, as well as supplements in the context of active treatment for biliary tract cancers, the strongest evidence is working in partnership with ARD. There are no individual supplements that have high quality evidence to say that they change your cancer outcome, whether it's symptoms, side effects, or in how the cancer responds to treatment itself. And so when we're talking about managing those common symptoms, what therapies help, what may not necessarily. So this is that snapshot that gives a summary of where we have the strongest evidence. The strongest evidence being that it's part of society guidelines. nausea, fatigue, sleep disturbances, pain, anxiety, depression, and neuropathy. When you look at this list of symptoms and you look at the current treatments out there for BTC, you can see just how prevalent, just how many people who get GemCis or GemCis plus an immunotherapy, whether it's durvalumab or pembrolizumab. Look at the proportion of patients on those clinical trials who report these symptoms. In cancer meetings, we talk a lot about anemias and your platelet counts and your white counts and all these, and your liver function tests, important numbers. But somewhere in there, in that slide, are staggering symptoms that often don't get attention. 42% reported fatigue. I suspect this number is even higher. 93% of folks getting a GemCis-based treatment reported nausea. And so when we're talking about how do we take care of the whole person, it's making sure we pay enough attention, not just to the liver function tests, not just to the blood counts, but to the whole person level symptoms that you see here that actually do impact outcomes, how much time a person is able to stay on treatment. And so when we look at integrative interventions for common BTC symptoms, again, I put this here as a reference for you to take a look at later. You can see that there are integrative modalities here with high quality evidence for the management of pain, for the management of nausea and vomiting, for the management of fatigue. And so when we look at some of the key evidence, mindfulness-based stress reduction has medium to large effects. This is how we interpret when we pool together multiple different studies. They may measure anxiety in different ways, but what we see are that the folks who had a mindfulness-based program added to their anxiety management, they had not a little, not none, they actually had a medium to large impact. Same thing when cognitive behavioral therapy was combined with mindfulness to reduce depression scores in people with cancer more than therapy alone, CBT alone. And so when we look at where we can place select integrative approaches, you can see how there's a real opportunity to personalize. If you're not feeling anxious, but you are feeling profound fatigue, partnering with your oncology teams and an integrated medicine team, if you have access to them, can really help come up with a plan around what you're going through. And so I'll in the next couple of slides as I wrap up, we'll talk about what does an integrative approach look like, just as an example. And you'll see me bring up fatigue over and over again, because it truly is one that's just, okay, it's fatigue. It's just fatigue. Talk about things that dramatically impact day-to-day life, but are underrated, to say the least. So what does it look like for an integrated medicine consultation and working with an integrated medicine team to personalize and take an evidence-based approach for cancer-related fatigue? So we have natural and mind-body approaches that are proven to help, that are in our cancer treatment guidelines. And there are over 100 clinical trials. There's a version of this talk that I give to our colleagues in oncology, and it's just loaded with numbers for the numbers audience. I'm happy to share that with you as well. But the fact is, it's that non-pharmacologic treatments. So pharmacologic treatments could be a stimulant, a little baby dose of methylphenidate or Ritalin, 5 milligrams. There is some data to show that that can help with fatigue. But when they did the head-to-head comparison, non-drug therapies, exercise, we've been talking therapies, were more impactful, reduced fatigue more than just taking a medication alone. When we're talking about exercise, I want to emphasize that this is not about running on the treadmill. This is not about swimming across the English Channel. Exercise, the ideal threshold for exercise, ideal, is moderate intensity. That doesn't mean you should be sweating profusely and, gasping for breath. It means that you feel that your heart rate has gone up from where you are when you're resting. It means that you're pushing yourself enough to where you feel yourself working, but that you're still able to have a clear conversation. So when we're talking moderate intensity, we're not talking about actually working yourself up to exhaustion. Moderate intensity is very different for me than it may be for you and you and you. So when I say, that's why no one ever gives you a heart rate threshold or gives you any type of number. If you feel like you're pushing yourself above what you would do at rest, you're actually you're hitting what the ideal is for an exercise intervention. And so when we look at, if I were to see you for cancer-related fatigue in the last few minutes, if I were to see you for cancer-related fatigue, we would talk through, okay, what does it look like? After, of course, we do the history, the exam, we put all the pieces together. We would talk through what does it mean to actually have an exercise plan in place. Then I start with the numbers because it is so encouraging. Let's say I blanked out exercise here. Studies show that blank reduces fatigue by more than 50% in people with cancer. You're like, I would say, sign me up, doc. Send the prescription to my favorite Walgreens. And then you realize that it is actually a combination of things you can do without ever needing a prescription. The trials were as few as 3 or fewer times per week. Sessions, 60 minutes or so. They don't all have to be at once. 60 minutes 3 times a week, 180 minutes a week total. You can split it up differently. And so where the health system can make a difference is this last part that you see here with support. Supervised programs are twice as effective as someone trying to do it on their own. This is true for most of us in medicine. Don't take our own advice. Rarely take our own advice. So we're all in the same boat when we talk about what can a cancer center do. There's a big difference from giving a handout that says, here's some guidelines on how to exercise, and actually having a program with the physical therapist, with the occupational therapy team that provides that support that doubles how much benefit you can get from an approach. And so I have a few more slides that I'll leave as part of the deck that you can take a look at that go into what is the place for yoga. This is not meant to make you contort in different ways. It's a combination of stretching, balance, and truly the mindfulness component. Mindfulness-based stress reduction, cognitive behavioral therapy. These are the summaries of, again, over 100 clinical trials with several thousand patients with cancer. And so I want to leave by sharing that when we look at the evidence, the current evidence-based practices that are the integrative evidence-based practices, you have multiple at your disposal to help with very common and underappreciated symptoms that go with the BTC treatments of today. And so talking to your team is the best place to start, And then understanding what kind of resources are there in the cancer center, in that clinic, and then what are there in the area. This is where I emphasized ASCO and SIO because there's so much info out there. There's so much information. And so looking to the trusted sources within oncology and integrative oncology is a key technique almost to have in the back of your mind as you're searching for information on integrative approaches. All right, I will stop there and hand it back to you.
Oh, that was lovely. Thank you. I would say part of the global research priorities is that we had a patient group and all of the things that you talked about are things that they want to know about. Nutrition, these are things that they can control, right? They can't control the disease, they can't control, but they can control what they eat, they can control if they exercise or not, they can control if they're taking supplements, so that they just want to know. And I think there's a lot of hesitation on the doctors to recommend an exercise program or to recommend eating. And so it becomes a really tricky spot for them. So thank you. That was lovely. I have to talk with you after. Okay. I want to introduce Dr. Tarita Griscoll. Tarita is a registered dietitian, and we're very excited to hear from you. With 9 years of experience in oncology and nutrition support, she currently serves as the oncology nutrition supervisor within the supportive care clinic at UAB, where she leads efforts to provide evidence-based nutrition care for patients all throughout the cancer continuum. Since joining UAB, Tarita has worked extensively in the inpatient setting as part of the multidisciplinary nutrition support team, helping critically ill patients maintain their nutrition status through enteral and parenteral nutrition support. Prior to UAB, Tarita practiced in Atlanta with a focus on critical care, oncology, and nutrition support. She holds advanced certifications in nutritional support and diabetes education. Tarita is passionate about delivering high quality, evidence-based nutrition care that empowers patients and supports recovery.
Okay, can everyone hear me okay? So two caveats here. One, I am not a physician, so sorry about that. And then I actually don't remember what the second one was. So I'm here just to chat about nutrition, and it's something that really excites me. So we eat every day, and there's just so much about nutrition that can really impact how you feel, how things are going, and there's just so much evidence also to support nutrition in cancer in particular. So we'll get started. We're going to talk a little bit about physical activity, and then we'll go over nutrition recommendations, and then specifically nutrition impact symptoms. So these are going to be issues where maybe there's a barrier to your ability to eat that's caused by a cancer treatment. So the guidelines for healthy eating and physical activity, one, we want to make sure we're working to achieve and maintain a healthy weight as much as possible. Being physically active, any sort of movement is going to be beneficial. Limiting sedentary behavior, so that's sitting down too much, which I know all day, that's pretty much what everyone's been doing, is sitting and listening. And then eating a healthy diet. So a lot of these have been touched on before, but the benefits of physical activity, especially with these treatment-related side effects, include reduction in anxiety, depression, fatigue. There's some studies that support in improving treatment tolerance. And then one of the biggest things for physical activity is helping retain muscle mass. So that's going to be crucial. Again, any movement is beneficial, so any is going to be better than none. It's been linked also with lower risk of many types of cancer. So when I talk about physical activity, I talk about it throughout the whole cancer continuum. So with things like prevention, treatment, and then after treatment. So a lot of times we're just not moving enough in general. So getting in any sort of activity is going to be beneficial, as well as limiting the time that you spend sitting. So for the people who love numbers, and I am one of those, aiming to get 150 to 300 minutes per week of physical activity. And this is going to be that moderate physical activity that you had touched on earlier. So walking, when I talk about walking, I don't usually mean window shopping pace. I mean, a little bit faster than that is what we're going for. Dancing. There are a lot of studies for the benefits of gardening with cancer. So getting out in the dirt, making sure you're doing things like that. And then if you're gardening vegetables, that's just an added bonus. So getting in more activity and then limiting the amount of time that you spend sitting. So these are just some quick tips of how to do that. So a lot of times maybe you're watching TV, get up and move a little bit during a TV commercial. I know some patients I have are seriously doing squats during their commercial breaks. If that's not for you, just getting up is still going to be beneficial. Light housework can help. And then also if you're working and you sit a lot for your job, I sit a lot for my job, setting a timer so that you're moving a little bit in between appointments or whatever it is that you have to do. And then I always say you can do a walk and talk. So sometimes walking for meetings, walking with a friend. If someone is not close by and you're always calling people, that's going to be another good time that you can do that while walking as opposed to sitting. So nutrition recommendations. This is a little bit more of my wheelhouse as a dietitian. So this here is the American Institute for Cancer Research recommendations. It talks about cancer prevention, but again, this is going to apply across the entire cancer continuum. So when we're looking at things like prevention, this is recommended as well during treatment and then after treatment as much as possible. So following these guidelines as much as you can is going to help, but we're going to talk about some of the issues that can come up if you're not hungry or not able to eat. But I get a lot of questions. People come in and say, okay, Karita, I heard, I can't have any sugar anymore. My mom told me this, my dad told me this, the random person on the street told me that. So there's a lot of information out there, but looking really at the evidence, and that's one reason I really appreciate the American Institute of Cancer Research, because they're strictly looking at nutrition and physical activity and the impact it has on cancer. So going to this website can also be really, really helpful for if you're wanting some specific guidance in terms of cancer fighting foods and things like that. But we'll get to what I call the good stuff. So what to eat? I get this question a lot of, okay, is there something that I really need to avoid? And so there are some foods that are less beneficial. So your red and processed meats. I'll touch on processed meat first. So that's going to be anything that is smoked, cured, or salted. Let's think things like bologna, bacon, sausage, those sorts of foods, not beneficial. They have the strongest recommendation of things to avoid. This is related more so with colorectal cancer, but all the guidelines would recommend avoiding processed meat as much as possible. Then we're moving over to the red meat. So red meat is going to be from any animal that has 4 legs. So you'll hear me say a lot, the fewer the legs, the better when it comes to your meats. So red meat, 4 legs, beef, pork, lamb. That's something that you want to limit and not have too much of. So the recommendation is 18 ounces per week. Usually I just say a pound a week because that's a little bit easier to remember, but no, you get a bonus 2 ounces here. So the fewer the legs, the better. And I also like to point out, this is not cumulative. So if you ate 10 ounces this week, you don't get a bonus 8 ounces next week. So keep that in mind. 4 legs is going to be our red meats. 2 legs is what we're going to lean toward. Lean toward a little bit more. So chicken, turkey, those have 2 legs, great source of protein, less saturated fat, which we also want to be mindful of. You know what doesn't have any legs at all? Fish, right? Beans, lentils, no legs either. So when we're looking at protein sources, the fewer the legs, the better. Okay, let's talk a little bit about sugar and cancer. So I get questions about this frequently, and we don't want to 100% cut out sugar. There are a lot of foods that are very beneficial that have sugar. So for example, we're looking at things like fruit, apples, peaches, naturally sweet. We want to have those in the diet. They have a lot of benefits, good source of soluble fiber, so it can help with managing constipation, diarrhea, those sorts of things. Where we get into trouble has to do with our added sugar. So that's when we're talking more about apple pie, peach cobbler. We add sugar to that, and that's what we really want to be monitoring. So in general, especially in the American diet, there's too much added sugar that's going in, and it can creep up everywhere. The biggest source of added sugars in the diet is from your sugar sweetened beverages. So if you were to go back to that slide from the AICR guidelines, their recommendation is reducing your intake of sugar sweetened beverages. So things like soda, sweet tea, lemonade, Kool-Aid. But candies and sweets are going to be another source of that too. But the biggest is your sugary drinks. So switching to water, coffee, unsweetened teas, as long as it's unsweetened, that's going to be a good option. But there's some wiggle room that you have. So it's not that you have to 100% only be doing unsweetened 100% of the time, but cutting back is going to be very important. So these are the recommendations: 25 grams of added sugar per day for women, and then 36 grams of added sugar per day for men. So when I talk about this is the limit, so the less is going to be better. But if you need a number of what you're looking for, that's what the recommendations are. This is coming from the American Heart Association. And again, there's a little bit of wiggle room, and I'll just use like a pumpkin spice latte for an example. Very, very sweet, a lot of sugar in that. If you were to go home and make one yourself, generally you're not putting as much sugar in there for that level of sweetness. So a lot of times it's being added into food. So when you're able to make food yourself, generally people are adding less sugar. So we've talked about the things of, okay, what do I have to avoid? Let's talk about what we get to eat. So when I talk about nutrition and the recommendations for cancer in particular, but this is supported for several different chronic diseases, looking for a plant-forward diet. Notice that I'm not saying 100% plant-based. That is not necessary, nor is it supported by the evidence that you have to be 100% plant-based, but getting in more plants. This is a little plug for meeting with a dietitian. If you are, for example, plant-based, we can talk through that to ensure you're getting in enough protein and some other nutrients where you might be at risk for low zinc or B12, those sorts of things. So we still want to make sure you're having a well-rounded diet, but eating a diet rich in your whole grains, vegetables, fruit, beans, and legumes. So this just goes over some of the serving sizes for fruits and vegetables. Thinking a cup for the fresh frozen fruit, a fist size if we're talking about something like an apple or a peach. Vegetables, you can divide those up in a number of different ways. We've got our non-starchy vegetables, we've got our starchy vegetables. Starchy vegetables are okay. So I had a patient the other day who asked me if it was okay for her to eat sweet potatoes because someone had told her sweet potatoes were fattening and she needed to get rid of them in her diet. And I was like, no, sweet potatoes are going to be great. Good source of beta carotene, good source of carotenoids, lots of benefits there. So those starchy vegetables sometimes I think can get demonized when we're talking about things like the sugar. But again, we're worried about added unnatural sugars as opposed to what's naturally present, especially in those whole foods like your vegetables and your fruits. This is just a shout out to the beans, lentils, and peas. So I love this picture. Again, these don't have any legs. So good source of protein, good source of fiber. So that's something we always want to be getting in more of. I generally recommend having at least half a cup of beans or lentils every day. So again, this is that New American Plate, 2/3 of it coming from plant sources, 1/3 or less coming from animal protein. So we'll talk a little bit about nutrition impact symptoms. These are going to be some of those barriers that can keep you from eating enough. So maybe you're able to eat, but you're not able to maintain your weight. And why is this really important? So malnutrition is a serious issue and it can cause a lot of negative impacts. Cancer patients, it's estimated that up to 80% of cancer patients experience malnutrition. And so if you're not able to eat enough and maintain your nutrition status, usually that means you're losing weight. And I wish it was fat that was the first to go, but generally it's going to be muscle that's the first to go. And we want to hold on to that as much as possible. If you're undernourished or malnourished, you're at a higher risk for infection, you're at a higher risk for the negative side effects of the treatment, experiencing those. And then it can also just be lesson dependent. So if you're not eating well, you don't feel as well, you're a little bit weaker, you're going to experience more fatigue. So paying attention to that nutrition status is just really, really important. And malnutrition can be a little bit tricky if is malnutrition really going on. Again, I would say this would be a time where contacting a registered dietitian can really help with that, because there are some markers that we're looking for when we're looking at malnutrition. But if you're experiencing unexpected weight loss, if you don't really have much of an appetite and thus you're not eating, that can really be one of those red flags for malnutrition. If you're experiencing frequent nausea, vomiting, diarrhea, our concern there is that maybe you're eating, but it's not staying in your system long enough for absorption. So those would also be a sign for malnutrition that we want to look for, as well as any sort of swelling in the ankles, legs, or belly. If you're having wounds and they're not healing as quickly, or maybe not healing at all, that can be a big indicator of malnutrition. It can be related to other things, but sometimes we'll have consults just because of poor wound healing and people aren't getting in enough protein or enough vitamin C, things like that. So one of the main reasons good nutrition status matters is it can help you maintain your treatment schedule. So if you're malnourished, that can lead to pauses in treatment, and that's something we really want to avoid at all costs. So these nutrition impact symptoms, I talk about them as barriers to good nutrition, barriers to good eating. So what I touched on a little bit earlier had to do with sort of this ideal state if you're able to eat those fruits, vegetables, whole grains most of the time. And that is what we want. But sometimes you're not as hungry and maybe something else sounds a little bit better. We can work through that and making sure you're hitting those calorie and protein targets. That's going to be crucial. For a lot of these issues, small, frequent meals can help manage these symptoms. So if you have a poor appetite, or if you're dealing with early fullness, switching from that 3 larger meals a day model and going to smaller meals can really help with that. I recommend scheduled eating a lot, because sometimes if your appetite's not there, you forget to eat. So I might ask, what did you eat yesterday? And it turns out you didn't eat at all, maybe because you just weren't hungry. So scheduling those meals can really make a difference too. So when we're dealing with fatigue and low appetite, there's that small frequent meals, using nutrition shakes. So you've got your standard shakes, things like Ensure, Boost, Cake Farms is another. And there are a lot of nutrition shakes out there. So getting with a dietitian to help you figure out what's going to be the best shake for you can be helpful, because there's a lot of different issues that are going on. And so now with a lot of the weight loss medications, there's a specific nutrition shake that's targeted for that. That may not be the best fit when we're working on improving nutrition and increasing calories and protein. So just there's that little caveat there. I always encourage having snacks at the bedside. So if you're really, really tired and maybe you're not getting up and moving as much as you would like, having some snacks there that are ready to grab, whether that's a nutrition shake, whether that's peanut butter and a spoon, whatever it is, having that at the bedside can really help. And then we can also help with doing things like frozen meals or meal deliveries. So you've got, the Blue Apron or something like that, what could work for you with the cancer treatment that you have, because there are certain things where we can tailor it, and there can be medically tailored meals as well. So again, I talked about scheduling meals instead of waiting for hunger. That's going to be important. With nausea and vomiting, small frequent meals, there it is again. Your bland starchy foods and clear liquids. And sometimes also separating your liquids from your solids with your meals can help. So a lot of times we'll take a sip of something to drink, we'll eat, we'll sip. Separating that out can really make a difference too when it comes to managing nausea and vomiting. And I'd always like to say, when I talk about this is alongside those medications that you're taking for supporting that as well. So if you're on some anti-nausea medication, time your meals for when that medication is going to be at its height so that you're able to eat a little bit more. Early fullness is one of the big ones that I see. So maybe you eat a couple bites of food and then you're done, you're full. That's very common. So small frequent meals can help with that again. So I know I touched on that a lot, but it really is one of the biggest recommendations that we have. Prioritizing nutrient-dense foods, doing those nutrition shakes can help. And then also, when it comes to liquids for early fullness, that can actually make a big difference because it leaves your stomach a little bit faster than a solid meal. So that could be another reason that a nutrition shake or a smoothie could be beneficial for you. Diarrhea, small frequent meals again there, making sure you're staying really well hydrated. For every loose bowel movement, an additional cup of fluid would be recommended. And you might need some electrolyte replacement, so an electrolyte drink. Avoiding caffeine, alcohol, anything that's really spicy, and then avoiding sugar, alcohol. So sometimes if you're chewing a lot on sugar-free gum, that can be contributing as well to diarrhea. And again, this is also just supporting alongside some medications too. Constipation, hydration is really important for that. When I talk about bowel movements, I'll talk about that pretty much every time you meet with me. It's called a bowel movement, so I say you gotta move. So physical activity can really help with staying regular. Making every bite count. So when you're not eating well or you're not able to maintain that nutrition status, every single bite of food is going to matter. So let's talk about how do we add calories to those foods that you're already eating. Here are some suggestions of, adding peanut butter to oatmeal. You're not consuming more oatmeal if you add peanut butter to that. So these were just some recommendations there. How to make a nutrition appointment at UAB. Ask your medical team for a supportive care referral for nutrition. We are here for you, is what I like to say. So if you want to meet in person, we're available in the Kirkland Clinic, we're available in the Whitaker Clinic, which is right next to the Kirkland Clinic. So you can do an in-person visit with us. We're at Acton Road. Once a week, you can meet with us there. Telehealth is an option. A phone call is an option. Whatever it is that you need, we're here for that. If you're admitted to the hospital, it doesn't matter what hospital it is, hospitals have to have dietitians. There's likely one on your case, but if you have not met with a dietitian, always just ask. They're there to help you. And here we work really closely with the inpatient team. They're in the olive green scrubs if you're ever admitted. So our supportive care clinic, we have a lot of different modalities available to you. Massage therapy, we have an exercise physiologist, counseling, nutrition support, chaplains, whatever it is that you need. Really, we have a lot of options available. And I always say UAB is just a big place. And so sometimes people just don't know. So always ask, always share with your team what's going on, and they can likely get you plugged in where you need to go. And then these are just some references. So thanks for your time.
Thanks to both of you. I'm sure we just have a few minutes for questions. Do any of the patients have questions about nutrition or integrated defense? Heidi?
What was on two of your slides? It had a capital letter TENS. What does that? TENS. What is that?
Has anyone used a TENS unit for various books? You want to share with us about that experience?
Stick it on you. So like a little pulse. It's like a little electromagnetic pulse that I don't know if it's loosening or not.
Oh, okay.
So for any type of muscle aches and pains, the physical medicine and rehabilitation team or the PT teams would recommend you get a TENS unit, either through your insurance or where I go for all my things with like Amazon. And if you just put it on at a certain duration, you'll feel it shouldn't be painful. But what essentially results is reinforced relaxation.
And can I just say, both of you had such informative, it was awesome, and so much information that I can use to take back to share with patients at home. It was Excellent, thank you both. So
You're all officially ambassadors for nutrition and integrative needs.
Yes, go ahead.
I had a question, so you have been 2 days about Amazon and insurance. Is there any financial progress in the financial coverage for integrated modalities for patients?
So the question was about how do we make sure that our payers and those who agree to take care of us and our health actually follow through on responsibilities to cover evidence-based procedures. It is so variable when it comes to integrated approach. It should not be that varied. So probably maybe about 6 or 7 years ago, pre-pandemic, Medicare started covering a certain number of acupuncture sessions for chronic pain that was not adequately controlled by opioids. So this was part of where we saw some movement was with the whole opioid epidemic. What are some non-medication ways to help? Most of the integrated modalities are still out of pocket. Some insurances have started to cover acupuncture because, I mean, the evidence is like just even, you know, our cancer treatments get like one major trial and then they go for FDA approval. Acupuncture probably has like 10 to 15 trials, randomized control trials that show that it reduces pain and overall symptom burden. This is where advocacy is invaluable. And that was a lesson I learned early to mid-career stage. I was so focused on doing the trials to generate the evidence. And I started noticing that it's not actually being adopted into practice. It became clear that we need to advocate for federal policy at the federal level. Shouldn't matter what state you're in. Well, I'll take state policy in the absence of none, but policy at the federal level for payers to cover evidence-based integrated approaches that are guidelines concordant in the NCCN guidelines. So I'm happy to go with you to the hill any day.
I would like to go just a little step further on the integrative medicine to see where we are here. What about where it's legalized, the THC or medical marijuana / where it's not, the CBD? Where are we headed in that direction?
That is a really good question, and I feel like we should totally do a webinar on cannabis and cancer care.
Yes.
So we released the very first, we got it put together with NASCO, and we released the very first cannabis and cancer care guidelines just this past year.
Oh, okay.
And so guidelines are meant to look at all the evidence that's published about any particular topic, in this case cannabis, and look at where can we make a very good case, very strong case for using that product. Where is it the evidence is mixed? Where is it there just isn't the trials to back it up? And so we have strong evidence for nausea and overall well-being.
Appetite.
And to some extent, appetite actually was ended up being the mixed. Because some trials were positive, others not to. I mean, you first get the munchies and they're.
Yes.
Cannabis is it is illegal at the federal level. There are exceptions at the federal and across the states for medical use. And universally across the United States, cancer is at the top of that list, as well as neurodegenerative conditions and a couple of muscular conditions and but cancer is at the top list. So patients don't necessarily have to worry about getting into trouble if they have. No one's really tested what if you cross straight lines with a product that legal in one state and not legal in the other. This is an area where we really do need just a few trials. We don't need 100 trials. We actually just need a few. So we're working actively, and this is an area that's very close to my heart because our patients are miles ahead of us in science.
Yes.
We want to know, we need to know, is taking a product that's you know, whether it's a, you know, sublingual thing or a spray or whatever, that's, you know, 3:1 THC to CBD ratio. Is that going to help with nausea and appetite? So we have companies that are making high quality product that's reproducible. So when you get your, let's say you get you're on an oral cancer treatment, it doesn't matter what pharmacy you go to, you know that it's going to be the same thing. So we want to find manufacturers who have that same level of rigor for their product, that it is going to be the same no matter what dispensary patient goes to. So we're working actively with manufacturers, and we're working with the FDA. We're also working with the NCI and the NIH. We really need this type of thing.
That's great. I'm glad you
And so-
are doing that. That's great.
And it costs a ton less than the
Yeah.
latest immunotherapy trial.
Yeah. That's what they say, so that's why we're doing it. You're awesome.
I would have said for the this great session, right? I mean, thanks so much for such wonderful and practical talks. And I also want to, you know, echo the sentiment on how shall we get this to the patients? I mean, there is wealth of information here, really practical, a lot of things that we could do. But, you know, there are other avenues, doing much better job in advocating for something else, which we don't want to see, which we get to like ivermectin, fenbendazole, lithotripsy, like God knows what they are. But I think we need to ensure this goes to the patient level, and really greatly appreciate CCM's advocacy there. Wanted to ask a question to Charita in terms of diets. A lot of the times patients come in and ask, after the diagnosis of cancer, and I take low sugar diet, right? Zero carb diet. How about, you know, keto diet? You know, I can tell them that the sugar and cancer may be related before the added sugar, correct? Before the cancer develops, but you need calories when you go to the treatment. But how would you answer those questions? How would you help balance the calorie count versus the sugar? And that, I mean, it's been not proven to be a real thing, but you know, still the questions come up. So what would your advice be?
Yeah, thanks for asking that. I get that question multiple times a day. So, usually how I direct patients there is when you go too low on any macronutrient, so carbohydrate, for example, you really put yourself at risk for a lot of micronutrient deficiencies. And then especially with something like keto, there's, you know, not a lot of evidence to support that for this particular cancer type as well. So we would talk specifically about what's going on. And then with a reduction in carbohydrate in particular, there's a lot of strong evidence on the importance of fiber for maintaining your microbiome. And that's going to play a big role with your immune system. So we talk more so about those sorts of things and how it's really important. And then if I have a patient who is still, you know, really, really interested, I would, you know, we can do some guidance in terms of maybe incorporating a few more carbohydrates that we know are going to be really, really beneficial while still tailoring it to what it is that the patient is wanting to do. But my big concern is always we're putting you at risk of running into other issues down the line because you're not consuming enough of a particular macronutrient, which is really important. And that can have issues with energy, that can have issues with, you know, neuropathy and things like that later on if those nutrients aren't consumed.
A quick question. Recommendations on protein shakes, we get asked a lot of emails where patients are intrinsic to eat solids, and what kind of protein shake would we recommend? What do you look for? What do you recommend?
So when I'm looking at protein shakes, depending on the case, trying to get at least like 350 calories per shake give as much protein as possible. So trying to do at least 350, and I would say at least 15 to 20 grams of protein, but there are several out there that have 350 calories and 30 grams of protein. So if someone is not eating well, we would want it to at least equal close to what a meal would provide.
And I came across something that I learned from one of our dietitians. There is this boost to very high calorie.
Yes, food very high calorie is amazing.
It is
So,
500 calories per one pot.
420 calories.
Thank you for
Yeah.
correcting me. But
And
you know,
22.
depends on the calories versus the protein. I try to guide my patient in terms of, hey, let's try this versus that. And then there are also clear water protein shake.
Clear protein
There are
shake.
35, 40 grams of protein in it. And I mean, I think there are.
Myself, yeah. Yes, so there are a lot of good protein shakes out there, and we can also work with, so if someone is, having issues with dairy, the plant-based market for protein shakes has increased significantly. So to the point that if someone even needed a plant-based tube feeding, we can accommodate that and give them what it is that they need.
Absolutely. Thanks so much for saying at least few times that integrative medicine complements. It is not an alternative medicine to cancer. One of my biggest challenges is how to handle, as I talked about before, like ivermectin and bendazole. Some of my patients are taking it as they go through chemo and immunotherapy. Things that I don't know are how they both work together, work against each other. One is the philosophical question of how do we get the message across, but two, how to address that in the clinic. Like even a patient to patient discussion, although inside of me becomes a little upset or angry, a little, so please don't do that. It may affect your care. But then that message need to come across so they understand this. How do you balance that in your practice to let them know this is where we have to do, this is don't, and then what works for you?
I said one thing with that, I just wanted to add on to that. I think you would feel that if you know that your patient's telling you. But when we survey the patients, they don't tell you, because they're worried that you're gonna tell them to go off.
That's a
Right?
great point too.
So, yes. Spot on, and that was gonna be the stat I should have let off with, depending on which study you're looking at. 50 to 80% of patients who are taking a supplement, who are taking a child substance, actually don't tell their medical team about it. So there's a couple of key core principles I would share in the context of what you asked, which is incredibly important. The first is, whatever we feel, as with most situations, we're gonna have to acknowledge it briefly on the inside and then park it over here. But it's not about us and our individual needs, right? This is true for any of us. Second is recognizing that that person sitting across from you is in the fight of their lives with a life-altering illness, maybe even life-limiting illness. 3 is understanding their intent. If I don't know that already from conversations, it's asking, tell me what you're thinking about, what you're looking for this drug, what made you seek out this medication or this supplement, to get a better understanding of what it is they're hoping for. And it could be any of things. Usually it's, I want my cancer to shrink even more with this, or I want this, I heard this shrinks my cancer better than the Western treatment, so the alternative versus complementary. I heard that this is will help me with my side effects. Any of the above, right? And then it's trying to understand, what are their sources of information? What convinced you that this will be one that makes a difference? And then it's the way we provide, which is I ask for permission. Would it be okay with you if I share a few of my thoughts based on what you said and whatever? And the answer, I don't expect that it's always yes. If they do say that, yes, please go ahead and let me know. We simply don't know. There haven't been large-scale randomized control trials that compared Genesis versus Genesis plus ivermectin, or Genesis versus as those agents by themselves. When we looked at the laboratory data and how other animals like mice, their cancer actually didn't shrink. And so my closing statement is, I worry that what you hope for, and what I also hope for, I want your cancer to shrink, that there isn't the kind of information, evidence that would convince me that it's going to do what we hope it does. And then we talk about, what do we know about side effects? So these medications in particular, they inflame your liver, phase 2, right? And so what I say is, we have to keep an even closer eye on your liver, your blood counts, because if something is out of the ordinary or becomes abnormal, we may not be able to tell whether it's your cancer treatment or if it's the item. We have to recognize that at the end of the day, the decision is always the patient's. It's always the patient's. And so this is really no different. And I say that to all of us, regardless of whether we're a health professional or not, because we all feel some angst, frustration, whatever it may be, when the person across from us makes a decision that we would not have made. This is true for any SID. Whether it's ivermectin, whether it's what college to go to, or who to date, or whatever it may be, they may make a decision that you wouldn't necessarily make for yourself. But save your angst, because they're very much grounded in that ability to make that decision. And then the next thing is, keep telling me. That's what I tell them. I trust you to make the decision that's right for you. It's so important that you keep me up to date on what you decide and how you what you do from week to week. And I want to make sure we're following the law. That's my approach. And I sleep pretty well now.
Yeah, very good. Hey, thank you. We need to go to the next session. This is amazing.
It is indeed.
So much. Yeah. Oh, to introduce Dr. Mala. How great is that? All right. Wait, everyone say goodbye to Stacy. She's headed to the airport. Okay, so we're pleased to welcome Dr. Midhun Malla, Associate Professor of Medicine at UAB and Section Chief of the Gastrointestinal Medical Oncology at the O'Neill Comprehensive Cancer Center. His work focuses on hepatobiliary and colorectal cancers, with a particular expertise in biomarker-driven clinical trials and circulating tumor DNA to advance precision oncology. Dr. Malla leads multiple clinical trials aimed at personalizing treatment for bile duct cancer and is deeply committed to research education and improving outcomes for patients. And personally, I have to say, I think he's one of the best patient champions out there. Way back more than 3 years ago, yeah, yeah, and he used to just he would reach out to me, he would email me, and he would say, hey, I have a cholangiocarcinoma patient. Would you connect with them? Would you give them resources? He's like, I'm not sure I have anything here I can offer them. What can you do to help? And the minute that I got that email from him, I'm like, I adore this man, because we don't always get the doctors reaching out to us. So I encourage all of you doctors to strive to be like Dr. Malla. Thank you.
So much. That's so kind of you, Melinda. Appreciate it. Well, I know that the session now is the last one before that's holding you head out the door. So we'll make sure it is as informative as the day has been. And thanks so much for joining and also staying along all day. So we really, really appreciate the support These are my disclosures. We'll be talking about mainly today how targeted therapy and immunotherapies have really advanced the bile duct care. And they really do, and hence we're also so much excited about the integrative medicine we talked about, is because due to these advances, our patients are living longer. And when they live longer, they're going through the side effects or the treatment related effects that require much more integrative care. And that was a fantastic session. And hopefully this session would also leave us with more hope and a lot more enthusiasm as a community of what we could do better. One of the disclosures I want to quote is I used some AI to generate some pictures that could be more informative, so they could be coming soon. So really, I think the agenda today is just understanding cholangiocarcinoma, what we've been doing all day, to cover what are the cancers, what's the treatment overview, what do we need to know at the patient level, advocacy level, like what do we need to know, and how do we bridge the gap between the physicians, patients, tertiary care referrals, second opinions, expert doctors, supportive care systems like we talked about, and so on and so forth. Not going to belabor this as much, but biliary tract cancers, as the name goes, they originate from the bile duct, and depending upon the bile ducts, whether they are from the liver or from outside the liver, they are either intrahepatic or extrahepatic, and that really is important for us to know, is because there's a lot of development of mutations specific to certain location of the cancers and also treatment options. With regards to the statistics, although liver and bile duct cancers are not in the top 10 as of 2025 and even 2026, they're about top 5 and 6 in terms of mortality, and hence we're here talking about these cancers, right? As part of February being the Cholangiocarcinoma Awareness Month, we have about 10,000 cancers in the United States diagnosed with bile duct cancer each year. Going back to the point of where you're able to diagnose them more, I think it could be a lot of factors, but that's a significant number. And it is, in fact, the second most common liver cancer in the world. And hence, I think we really, really need the advocacy and support as a team together. So I've divided my talk into these sections, as you can see, starting with workup, which has already been covered. So I'll breeze through it. Treatment planning, we covered some of it, but mostly my focus would be in medical oncology side of things. And then also how important a second opinion is, genomic sequencing, clinical trials, and support systems. So starting with the workup here, we talked about the symptoms, and the symptoms really depend on the location of the cancer. And sometimes we may not have these symptoms until it is stage 3 advanced or stage 4, and that's okay. I mean, that's something it's not in our control, right? We're talking about controllable, uncontrollable factors. And cancers which are outside the liver in the bile ducts, they tend to produce symptoms early compared to the cancers within the liver. And that could be yellowish discoloration, pale stools, itching, so on and so forth. Now, risk factors, which we talked about, I think, there is viral hepatitis, there is smoking, bile duct stones, alcohol, liver fluke, inflammatory bowel disease, so many factors that could contribute to some autoimmune disorders as well contribute to. Few tidbits on workup. Make sure there is CT or an MRI at a quality CT MRI machine with IV contrast and a chest CT, including the whole body. Is a lot of the times I also get the question from a patient says, why was not a PET scan done? So to be honest, we don't really need a PET scan as part of the staging purposes per NCCN guidelines, right? But we do when we have a subtle thing on the CT or an MRI that we're unable to differentiate it. And that's something we discuss as part of multidisciplinary team, but not something we require commonly. There are some laboratory tests that are needed and perhaps help us in the management. But most importantly, I cannot stress this enough, which is the theme of the day in the morning, like multidisciplinary evaluations. It's just not one person We just need a team, a village, right? Now that takes us nicely a segue into the treatment planning and seeking an opinion at secondary or tertiary center, specialized center, especially who are experts in cholangiocarcinoma management. At UAB, we are fortunate to have a great team of multidisciplinary folks. This is from, we were talking this morning about the fancy glass door rooms. Unfortunately, we don't have those. It's a closed room with one or two small windows, but we make a lot of progress there. And this is one of those places, where we bring the patient in rather than have the patient ship around to different doctors, different days. We make sure they see them all on one day in an afternoon. But these are some of our patients coming from 3 to 4 years ago, 3 to 4 hours ago, I'm sorry. And really they appreciate it a lot, especially when we all come together and provide the care. Now, and we really need that group and a bigger group is because the journey is quite complicated. I've here listed very briefly about neoadjuvant, adjuvant, metastatic. That summarizes everything up, right? But neoadjuvant is something before surgery. Surgery is really important, as we talked about earlier today. And then what happens after surgery is adjuvant therapy. And then metastatic therapy is for stage 4 or advanced care. That's where the medical oncologist. But then there is overlap, right? I mean, we need help of the surgeon at any point in the care. We need help of our interventional radiology. We need help of our radiation oncology. So it's just a continuum of care and we need the entire team to work together. So now surgery aspect has been talked about this morning, has provided a median overall survival of almost up to 3 years for our patients with cholangiocarcinoma. What adjuvant therapy does with the addition of one pill for 6 months, of course, the pill has to be taken about, a good 6 to 7 pills a day for 2 weeks on and a week off. That has improved the survival from 3 years to almost 4 to 5 years across studies. So that's one thing, regardless the cancer as of today, regardless of in the liver, outside the liver, we recommend our patients to take that one pill or IV drug if we can't tolerate them, 5FU-based therapy, really. There are a lot of data that showed that more therapy after surgery is not useful. So tell my patients, if they come and say, I had the surgery, I would like to get chemotherapy, immunotherapy to make sure it doesn't recur. I tell them, what more doesn't mean more for you, maybe even harmful. That's all in the red boxes. The take home point there is more doesn't mean better. Now, I'm really an advocate of circulating tumor DNA. There's a lot of excellent, exciting data coming out there yet. What it is the cancer cells, they release the circulating tumor DNA into the bloodstream, and it is a powerful tool that can be detected in the blood. And the reason it is powerful is because it is a real-time dynamic biomarker. Like, for example, if you have a CEA, CA19-9, what we are testing today is perhaps a representation of the blood test that was performed 2 to 4 weeks ago. But it's because of their half-life. But the circulating tumor DNA has only a half-life of 30 minutes. So what we check today is performance of what today's level is going to be. So there is data, there are a lot of applications of the circulating tumor DNA, throughout the continuum of care. I think one, it can help determine which patients are more likely to have cancer recurrence. And we currently have 250 plus patient data in the process of publication for cholangiocarcinoma. Hopefully comes out soon that can help guide us in terms of identifying these patients who are at high risk of cancer recurrence. Now, then if cancer is recurring in the blood, it can also help detect earlier recurrence on the scans. And it can also help biomarkers, gene mutations. For example, one of our patients spoke today, Aaron Drake. We used a circulating tumor DNA guided approach that we were able to identify MSI high for him, and that actually changed his landscape of therapy from where he was bilirubin of 9, a 13 centimeter tumor, to cancer-free 2 years later. treatment response monitoring is something that this is evolving, and would be a little cautious about how we use it, but there is a lot of data coming out as well, especially in FGFR and those targeted alteration space. So important aspect to discuss with your cancer doctor is, can we have this testing done, is how just have a discussion or have a conversation, right? So what are the take-home points of what we talked about so far is, number one, surgery offers cure, provides an average survival of 3 months. Again, that's average. Chemotherapy after surgery could improve that to 5 years from 3 years. So something to talk about. Personalized medicine, really key. Not everybody have a cancer recurrence. Somebody may have it, somebody may have it at 3, 6, 12 months, 2 years, may not come back. So that's really important to personalize the care. And can't stress this enough, important to participate in clinical trials. Dr. Akshay is going to talk about, the clinical trials in the next talk after this. What are we doing and how are we able to conduct those at UAB? But the next, would like to delve into genomic sequencing and comprehensive genomic profiling. I would say bile duct cancer is like the next lung cancer, or it's a target-rich disease, right? There is wealth of data only when we can check for it. If we're getting a biopsy, if you use the right tissue and the sample and look for it, there is wealth of data or information we could find. About 30 to 40 out of 100 patients, they harbor targetable alterations that there are currently FDA-approved targeted therapy. That's significant, right? And these alterations, they vary based upon the tumor coming from within the liver or tumor coming outside the liver. And on the right, you have a lot of those alterations and what is the recommendation from NCCN? I didn't make it up, it's from NCCN. There are a lot of targets on the left, which some are rare to find, some are very common to find. And Stacy has elaborated this morning quite well. There are multiple targeted therapy approvals, FGFR2, IDH1, pemigatinib, futibatinib, zanidatamab more recently, and then tumor agnostic. What does that mean? Is these are regardless of the tumor type, like bile duct, lung cancer, breast cancer. There are some approved therapies like MSI high, NTRK fusions, BRAF V600E, RET fusions, TDXT with HER2 amplified tumors. So there's wealth of information. Can't stress that enough. What does the real world data say, right? I mean, yes, there's data, you find it, but it's so fascinating to find out in the real world data across 8 big institutions with intrahepatic or extrahepatic cancers published as of 2023, only 60% of the patients are getting tested with intrahepatic cancer. And only 43% of the patients with extrahepatic cholangiocarcinoma are being tested. So I hope this changed probably in the last 3 years, and we need to really advocate and push for that to even further the change. Again, you don't test for it, you don't find it. One of the caveats here we also need to appreciate is tissue availability of doing this testing is a challenge. We have Dr. Rose here who understands, and we have those conversations in the clinic on the multidisciplinary tumor boards as well, is how to get the tissue adequate enough, especially if it's extrahepatic. We only get FNA samples, and these FNA samples, the amount of tissue within them makes it challenging to run this gene sequencing, which they do require a good 200 plus cells, sometimes even to look into it. Now, these are all the approved therapies for bile duct cancer. Like if you have an IDH mutation, which is almost about, which is almost about 20% or high, there is an approved treatment option. And we have FGFR2 on the right-hand side, 3 approved therapy, actually 2 now, but hopefully the third one coming up soon. HER2, NTRK, MSI high, KRAS G12C, and this is going to be even changing landscape in 2026. By the end of the year, we're going to see a lot of KRAS targeted therapy from pancreas cancers, which is about 90% when compared to cholangiocarcinomas, it's up to 30 to 40%. So there is going to be a lot of excitement within the KRAS space. There's a BRAF mutation, not as common, but significant response rates with the therapy. But now you could ask me, well, we talk about all of this, but you still say 30 to 40% have those mutations. But what if there is no targeted therapy available? We have good treatment options in those space too, because there's a good 45-50% of our patients on the gray bar on your left, they may not have targeted therapy, right? I still see those patients in my clinic. And what is the timeline of development? As Stacy pointed out this morning, back in 2009, we have the GEMSIS all the way on the left, but now in 2022 and 2023, we have the addition of immunotherapy that has made significant progress, but still a lot more progress to be made. But especially if you look at the second line setting, this is where I feel like we need to make a lot of progress, especially for those patients who do not have those mutations. We only have chemotherapy. FOLFOX, FOLFIRI, not the best options, but those are the available better options. So pick those options as those things, and really need much more options that are generalizable for our patients who do not have targetable alterations. And as I treat my patients, what are the key clinical factors that I consider? And this is a paper that we worked is currently under publication, under review for publication. We worked on this paper for liver cancer, but I think this could be applicable to bile duct cancers as well. It's important to see what the liver function is on the top. Then how about the risk of bleeding because of the liver function, right? What about autoimmune diseases? Because patients may not be able to receive immunotherapy if autoimmune diseases, depending upon how controlled or uncontrolled. What about cardiovascular comorbidities? Thrombocytopenia, how are the platelet levels like? Have they had transplant before? Then we can give immunotherapy. And more importantly, how far do they live? If I'm offering them a treatment that it is not standard of care, the first question I ask them is, would you like to get it close to your home? So I still be available for you 3 months later and every 3 months to see you, so you don't have to travel all the way this far. That's really important in also choosing the treatment options and whatnot. And we have made significant progress since 2010. If you look at median average survival in 2010 was about 11, maybe 12 months or less. In 2022, you would imagine the number has only improved to 13, but the 13 is the average. However, there are patients who are living longer with immunotherapy. The tail of the curve on immunotherapy is significant. I'm seeing, for example, our patient Gonzalez today, she's 2-year survival on chemoimmunotherapy. That's all depends on how you combine the strategies and work as a team together. Now, let's say you're Fred having an FGFR2 alteration. That survival with the help of therapies, I mean, he's our, a poster child. I mean, he's like significant. I mean, he's somebody that I look up to, like almost had 4.5 years just on FGFR inhibitors and keep going. But we have, on an average, the survival triples to 35 months. And with more novel targeted therapy, it is going beyond 40 months as well. So that's the significant progress we are making, and that's important to keep in mind. Coming to clinical trials, I don't want to steal the thunder by any means from Dr. Akshay, but we do have great clinical trial team and great clinical trial options. I want to plug in for this study. Well, I mean, we have enrolled patients on this until December. The study has been closed, but there is currently additional study. We are currently enrolling newly diagnosed patients with bile duct cancers. Is the old immunotherapy better or the new 2.0 immunotherapy better? We are looking at those clinical trial options. Our own Dr. Akshay has a trial for FGFR2 fusion. So if you or your family, your somebody around you in the town are aware of these patients who are having these mutations and are not treated yet, we are using novel therapy to combine them with immunotherapy and see whether we are going to see much better benefit. And Dr. Akshay is leading them. And there are some that are open to be open soon. Dr. Bray, who was here this morning, is opening another study in the frontline setting. And I'm fortunate to have an approval from the company to lead a trial in Claudin 18.2, which has shown significant advantage or benefit in upper GI cancers like gastric and esophageal cancers. And there is a trial approved that I'm going to lead in the country using targeted therapy, Claudin, in the second line setting where we really need more options. Now, I cannot be running this, we cannot be running this without the support of our beautiful clinical trial team. So we have Lee in the room, if you don't mind standing up, Lee. And we have Anil, we have Kiran Andriano. I would like to have a strong round of applause for really what they do. We meet every week. This was a picture we took yesterday, and I think they have to bear the brunt of my pain to open the cameras and have the thing. But I mean, this is what we do every week, right? I mean, we meet, we make sure how our patients are doing on a trial. It really takes a village. I think Lee had conducted one SIV, like opened a trial before we came in, under constant discussions of how we can improve the care, keeping the patient at the center. So I can't thank them enough. Lastly, support system. I think we've discussed this already before, but integrative care services, they're right in the center, either pain management, symptom relief, emotional support, advanced care planning, nutrition support, family support, you name it. I think that's really key, as much as important as the chemotherapy or immunotherapy or the surgery, because it's the patient at the end of the day that goes through these treatments. And I think these really are going to complement the care, and can't stress that as enough. And as part of the integrative care services, I also want to plug in and thank our excellent GI pharmacists. Unfortunately, both of them, or fortunately too, both of them are unable to join. And the reason I say fortunately is because Amy had a baby on February 14th, so she's at home, and Erin had to go take care of her parents, but they are phenomenal. They help our patients who are on targeted therapy, chemotherapy, make sure their symptoms are addressed the right way, and significant help for me really in practice. Now, going back to our conversation, I think this is almost towards the end of maybe a couple more slides. What are controllable and what are non-controllable factors, right? I tell my patients in my clinic when they come in with anxiety, questions about what's the future is going to be, how long do I survive, and really those are not in our control, right? Even the stage of diagnosis is not in our control. Response to treatments, I really would want to provide them hope, but we don't know until we see those results in the scans. But what's controllable, as were alluded to in the prior talks, healthy diet, physical activity, avoiding smoking, staying positive, doing the mindful body therapy, those are significant. And I've seen, in my practice too, like fatigue can be targeted by the physical therapy. A lot of my patients who complain of fatigue, with the motivation we provide, with the exercise that they do, they come back later and say, you know what, I should have done this before. That breaking that jinx can really help them. That's a controllable factor. So I once again say focus on what we can control, and then leave the rest to I guess what happens in the future, right? Now, the biggest question is, where does patient advocacy fit in the journey? To be honest, as I thought more about it, I think there's no better place than right in the center, right? Starting from the workup all the way to the supportive care at the end, they are right in the middle and they help the patients. And I've seen my patients travel through in their journeys with the patient advocacy support. And I want to really thank CCF for what they do. Again, honored for them to be able to come to the state of Alabama and see what we have got to do here, and at the same time, what our patients can benefit from moving forward. So with that, I would like to conclude that together we are stronger. You're not alone. We have a multidisciplinary team that we work together for you. Knowledge is power. Always ask and seek second and third opinions. Focus on what you can control. Most importantly, integrative care matters, complements what we do. Quality of life is very, very important. Clinical trials are critical. They often represent the next standard of care. And I tell my patients, do not think of a clinical trial as being a guinea pig. you think of it as how you are contributing to the science. At the same time, think of it selfishly that if you're in a trial, you're going to get VIP experience, right? Really, right? The reason I say that is because you have a clinical research coordinator who is actually spying on us and spying on the patient, making sure everything is right. Because we also have an overarching committee to make sure we do things the right way in the textbook. So I think that always shown benefit for our patients. And lastly, stay informed, ask questions, seek expertise, and be part of the strong team. So with that, I think try to include some of our colleagues' photos. Again, it's a village to run the thing together, and I would like to thank you for your attention.
Okay, next up we have Dr. Mehmet Akshay. We're pleased to welcome him. He's the director of the Phase 1 Precision Medicine Program at UAB and Associate Director of the Hugh Call Precision Medicine Institute. His research focuses on developing innovative new therapies for solid tumors, with particular expertise in gastrointestinal cancers, hepatocellular carcinoma, and cholangiocarcinoma. Dr. Akshay leads multiple early phase and multi-institutional clinical trials, including novel immunotherapy combinations, and is deeply committed to expanding treatment options for patients through cutting-edge research. Thank you so much for being here.
Thank you for the lovely introduction, and I am so glad to see that we are having this symposium. I want to thank Dr. Mala for his leadership to put this together. It is an amazing event, I think, and I have the privilege to give the last talk. Thank you for that too. So these are my disclosures. Okay. These are my disclosures, and as Dr. Mala and others mentioned about cholangiocarcinoma is a global health burden. And unfortunately, a lot of the cases present with relatively advanced stage, either locally advanced or metastatic disease, and that really deeply impacts the prognosis of this disease, which seems to be unfortunately poor. In the United States, it's one of the important causes of cancer-related mortality. And with the advent of the molecular profiling, now we know that up to 40% of the cases of cholangiocarcinoma carry a potentially targetable molecular alteration, which I will get into detail in a bit. With the advent of the molecular techniques, now we have multiple targeted therapies, as Dr. Mala mentioned. So the molecular alteration or a mutation, what is a mutation? It is a molecular alteration that derives the cancer. It impacts cascade of events in the cell that leads to abnormal cellular proliferation, and the end result is cancer or abnormal tissue growth. And by targeting those molecular drivers of the cancer, we develop personalized medicine or precision oncology. And those agents, multiple of them are in the available treatment options right now, are all developed thanks to clinical trials. And starting from phase 1 to phase 4 studies, which is the most important way of advancing the cancer care in the precision oncology. When we look at the current approach in the guidelines in the newly diagnosed locally advanced or metastatic cholangiocarcinoma, clinical trials and chemoimmunotherapy are the standard of care. And if you look at the national guidelines, clinical trials at every stage of the cancer is actually one of the standard of care recommendations. In treatment refractory cancer, which is after the frontline therapy, clinical trials are part of treatment recommendations, as you can see on the right-hand side. And this list really keeps growing thanks to a lot of research in the precision oncology. We have several different targets that are already in use in cholangiocarcinoma.
So what is a clinical trial then? Clinical trials are research studies that test how well new medical approaches work in people, and they show us what works and what doesn't work in medicine. And all those new therapies must go through clinical trials before they are approved to treat cancer in the United States. Oftentimes, these therapies also are compared to standard therapies. And as Dr. Malla was mentioning about the importance and potential benefits of participating in a clinical trial, participation in clinical trial could be a way to get the newest cancer treatment, because these trials take time to conduct, and it takes, unfortunately, several years for those new therapies to become available for the wider use. So participation in a clinical trial would possibly allow the participant to get to use that medication sooner than many other people. Clinical trials help improve healthcare thanks to the combination of healthcare team and volunteer patients working on this together. And we either look into a new drug, new clinical procedure, or new diagnostic tool to advance the care of patients. There are basically, I'm going to skip the phase 0 trial. Let's say that there are 4 phases of clinical trials. In phase 1 studies, we determine whether a new therapy option is safe in human beings. They are done to find the highest dose of a new treatment that can be given safely without causing severe side effects. And in phase 2 studies, we determine whether a study is efficacious, if the study has signs of efficacy. If a new treatment is found to be safe in a phase 1 study to be used in human beings, a phase 2 clinical trial is done to see if that works in certain types of cancers. In phase 3 studies, we determine whether this promising therapy based on phase 1 and phase 2 study is actually better than the most commonly used, best available standard of care. So they compare safety and effectiveness of a new treatment against the current standard treatment, and side effects of each are also compared. If this clinical trial is successful, the new treatment may be approved for the use outside of clinical trial. And even though a study may show that the drug is effective, better than the best standard of care, it becomes widely used, but we may still need to know about this agent further, because the phase 3 studies can be conducted in up to 300, 400, even 500 patients in one cohort, but wider use may actually reveal some new side effects. So when the treatments are approved by FDA, they are phase 4 studies are conducted to really look at longitudinal effects of those agents in a larger patient population. But before a clinical trial can start, research must be approved. For investigational therapies, and investigational new drug application or IND application must be filed with FDA when a researcher wants to study a new treatment in humans. And this IND application has detailed information about the preclinical or laboratory studies that were conducted with this agent, and also the actual treatment plan in detail, and also potential risks that, as much as we know with that new agent, and also the details of the team that is conducting the clinical trial. And the research team must commit to getting informed consent from everyone in the clinical trial. And the research team must plan to get study reviewed by the Institutional Review Board, or IRB, and follow all the rules required for studying investigation and treatments. So it's a very tightly regulated process, and it is definitely based on consent of the participant. So what should you expect if you decide to participate in a clinical trial? So clinical trials have limited number of slots based on the sample size of the study. The slot is granted to a participant when the participant indicated interest and wants to consider this study, and we always give the consent form to patient, and we expect and want the patient to sleep on it, read about it, ask multiple questions, write down questions, and understand what they are getting into. And then the clinical research coordinator will schedule an appointment with the patient to sign the informed consent form with the provider. And every patient has chance to go over that again with the provider, and they are provided a signed copy of the consent form. And once the consent form is signed by the patient, screening procedures will start in the study, and these may include blood work, it may include EKGs, imaging studies, and sometimes research biopsies. But almost all of those procedures that are included in the schedule of events in a clinical trial are part of the safety of the intervention. Once the patient meets all the eligibility criteria and completes the screening process, the treatment can begin. And at that point, the patient gets a calendar and understands the expectations and the schedule of events, when to show up for the study. And the consent form the patient signs has all the information about emergencies, or whenever they have a question, whom to reach. So when you participate in a clinical trial, what is a typical day during the clinical trial visit? And each study might have different schedules depending on the phase of the study. Phase 1 studies tend to have more frequent visits because of the nature of the study, focusing on safety. So this is for a phase 1 clinical trial typical day. This happens in JP15 Jefferson Tower at UAV. It has a dedicated phase 1 unit. Usually phase 1 studies are conducted in a specialized unit because they require specialized sample collection and multiple time points throughout the day. The medication of the clinical trial is administered in that visit, and the healthcare provider would do a complete assessment, go over the side effects, because these are new agents. We don't necessarily know all the side effects of these agents, and we would ask detailed questions to the patients to understand how they are feeling while they are on this treatment, and we'll record that and make sure that they are okay to continue further treatment with this investigational agent. And the treatment visit on that day could last less than an hour or up to 8 hours, or sometimes 10 hours, depending on the style, the nature of the study and the need for multiple blood collections throughout the day. And that also understands how the body processes the drug and how the drug is distributed in your body. So it informs further steps of this drug's development in the process. And this, as Dr. Malla said, this takes a large team effort. And we have seen the pictures already, but this is our GI Med-Onc provider list, including our 6 attending physicians and nurse practitioners focusing on GI oncology, but we also collaborate with surgical oncology very closely to take care of patients with cholangiocarcinoma. These attendings here, faculty, focus on hepatobiliary cancers in general, and clinical trials are actually part of each step whenever you go to these clinics of these providers. Our multidisciplinary liver cancer clinic is unique. I wanted to mention about it one more time here. Dr. Malla mentioned about it. It is the only academic multidisciplinary liver cancer clinic in the state, and these clinics are actually not very common, but we are lucky to have one here. And we have representation from liver transplant surgery, interventional radiology, medical oncology, and radiation oncology. On a typical day, the patient is seen by all those one provider from all these teams, and we review cases in detail before we see the patients, and plans are developed in a joint plan manner. And clinical trials are also part of these discussions. If we have potential trial options for the patient in front of us, we would definitely mention about it and offer it to the patient as an option. Our phase 1 precision medicine team is a relatively large team, including multiple attending physicians and a dedicated nurse practitioner We work as a team, and cholangiocarcinomas as solid tumors are included in several phase 1 trials. Therefore, this phase 1 team plays a crucial role in taking care of those patients with cholangiocarcinoma. So we have several ongoing studies. Dr. Mala already mentioned about the Artemide study and the Gemini study. One of them is for after resection, and one of them is for newly diagnosed biliary tract cancers. We use biliary tract and cholangiocarcinoma interchangeably. They mean the same thing. This study still has slots available, newly diagnosed cholangiocarcinoma. Novel immunotherapy agents are explored in combination with chemotherapy in this clinical trial. We also have an investigator-initiated trial that is being conducted at 5 centers in the US. It is active at UAB. We actually started our first patient already, and this will also open at Ohio State Roosevelt Park, UC Norris, and Infirmary Health in South. So it's going to be in 2 centers in Alabama. I'm excited about it because we have very close collaboration with Infirmary Health, and I'm hoping that patients will take advantage of this novel therapy approach as well, essentially combining a targeted therapy with immunotherapy in this cancer. An up-and-coming study in combined hepatocellular cholangiocarcinoma, exploring chemotherapy plus immunotherapy combination. And this study hopefully will open in the next couple of months at UAB and 5 other centers in the US. So we also have phase 1 studies for all comers. We call them all comer studies. These cover any kind of solid tumor, not hematological malignancy. And phase 1 studies are safety studies, dose finding studies, but there is substantial potential benefit in participating in these studies too, because these are novel agents and some of them are actually quite powerful and efficacious. This is a pan-KRAS inhibitor, which KRAS is a common mutation in a lot of the GI cancers and could be seen around 20 to 30% of the 20% of the cholangiocarcinomas. This is a novel agent that targets multiple different types of this mutation. And this study is open at UAB to be offered for patients with KRAS mutations who had previous treatment. Another study along those lines is for HER2 activating mutations. This is also open for any solid tumor with a HER2 activating mutation, including the biliary tract cancers. And we have some other trials. They are not targeted therapy specific, and we would be more than happy to look into any trial options for any potential patient. And those are the slides that I have for this talk. Happy to answer any questions you might have.
Dr. Mala, and have a seat. We'll see if there's any
All right.
questions. Any questions?
Well, this was great. Quick questions for Kamala. There's been some suggestion that the timing of immunotherapy seems to have an impact on the outcome in lung cancer. Do you think that there's anything that can be translated to patients with biliary tract cancers? If someone's actually non-responding to immunotherapy, is there anything you can do to potentially activate their immune system? It's sort of an out-there question, but I'd love to hear your thoughts.
Yeah, I've seen that data recently presented in lung cancer, like when do you administer immunotherapy, like morning versus evening in terms of that benefit. I think it would be very interesting to see that, how that pans out in the liver, bile duct cancer, so on. So answer is I don't know. But I would imagine there would be similar impact. Again, that's my opinion, but I don't know. We don't know the answer, because I think there is data as well in immunotherapy in terms of weight-based immunotherapy, male versus female. I think there's a lot of data being generated as more and more research has been done. In terms of therapies that would potentially augment the response for immunotherapy, I know we both have worked together for almost 3 to 4 years in liver cancer, combining Y90 plus immunotherapy. I think that preclinical data of using Y90 or radiation therapies have demonstrated at the microenvironment that it would augment the immune cells, CD8, like cytotoxic T cells, which we have, which we need, that could potentially invigorate immune responses, more potentiate responses with immunotherapy, is definitely the hypothesis. I think, the patient that we have seen today, we received Y90 together with immunotherapy along with TACE, has had long durable responses. So, I mean, there is a lot of data utilization there, and I know you are leading a lot of research in that area as well. So hopefully we see some prospective trials, see together, especially for our cholangiocarcinoma patients. If they've completed 6 months of chemo IO and they're immunotherapy by itself, that could be the way we could add further targeted therapy, local, regional, or novel agents to see whether we could, to your point, Melinda, this morning, like what can we do together, right? I think a lot of areas of expertise there.
Can I just add to that there, Dr. Valle on our research, our CMO for CCF, this question came up and they actually dug into it. And so now I think AZ and Merck are looking to see if they can find time of day over and over again to see if it made a difference. So maybe we'll find out more.
Yeah, maybe.
Any other questions?
We'd like to ask also Ali, who's our nurse manager, and she was a phase 1 or the phase 1 before with the infusion clinic schedules in terms of logistics. If we can do immunotherapy in the morning versus afternoon, I mean, those are the things would be interesting to know as well, how easy or challenging it is to, schedule them, right? But want to get your insights on, what we provide, what services we do at UAB.
Hi, I'm Alex Riley, I'm nurse manager at the oncology clinic at Kirkland. And I also used to work on the phase 1 clinical trials program. So there are some barriers to being able to give infusions in the morning versus the afternoons. Because we also have to consider patients have to go to lab, get lab work, that can take an hour or two. You have to see the provider before your infusion. So people have to schedule all of these things prior to the infusion. So it is a multidisciplinary approach to get these patients scheduled. So that's definitely something we can work together as a team to accomplish if data reflected that it would be better morning versus afternoon.
Thank you.
I want to add something on the timing of the infusion. We go to great extent and aims to really improve survival for few months for our patients, conduct multiple large studies. If you could really change the outcome by the time of administration, it is music to my ears. I will definitely do everything to accomplish it because it's such a simple intervention that could lead to significant differences in survival. I think that would be a big gain. I would not hesitate to adapt it once I see it in a prospective manner.
Jamie, that's a question about the HER2 positive thing. Is that the HER2 expression level really important role for the responses related to the drug? Or drug resistance? Because recently, there's people from NCI for prostate cancer, they show, HER2 type of, HER2 expression related with endocrine type of the cancer, which has a larger play role for the drug resistance. I just wanted to use this species HER2 expression would play a role or not.
So you are asking about the degree of expression and its impact on the response. It really depends on the type of treatment that is being used. The definition of HER2 expression in biliary tract cancers is IHC 3+ or 2+, which is ISH positive. That is for the ADC and bispecific antibody and anti-HER2 monoclonal antibody agents. But more and more data is being looked at lower HER2 expression levels. And we actually have another study looking into HER2 1+ and 2+ in multiple solid tumors, as this is already established treatment in breast cancer. So the expression really matters for the modality, the agent's characteristics that we are using. And some of the studies are for activating mutations, not expression. So It really depends on the agent that is being investigated, but traditionally 3+ is where most of the agents would work in biliary tract cancers. For 2+, if you look at the trastuzumab deruxtecan data, I don't think it worked in biliary tract cancers or pancreas. In those patients, it has to be really real positive 3+. But different ADCs are looking into this, and some of the ADCs obviously will improve the approach. And then this would actually yield potentially responses in 1+ and 2+. Do you have anything else to add to that?
No, I concur completely. And to add to the HER2 expression, there is HER2 like a mutation too. It's not as common as the overexpression, but the mechanism of action, the drugs that we have for overexpression, for some reason, don't tend to work as well for the mutation. So we are seeing in some early phase clinical trials, the drugs that are coming out, they're giving phenomenal responses, like up to 70% or so. So they're going through FDA processes or whatnot. Again, boils down to the question of checking it, having the expertise of oncologist able to differentiate between an expression, mutation, alterations, like all things put together, and use us as a resource in the state of Alabama, right, to help guide in the trials. Like some of our patients who were almost towards the end of care for lung cancer with a HER2 alteration or a mutation on the therapy, living almost 1 year plus with 70% response on this drug. So a lot of new stuff happening there for sure.
Quick question for you two, Dr. Mola, or both of you guys. I'm speculating tumor DNA and using that. Do you incorporate it into your clinical trials? And can you do it in phase 1, or does it usually come in phase 2? Like, are you tracking that so that we have more data on that? And I see patients getting access to it in different. Some patients have access, some patients don't. All patients that we want it, but we're still all trying to get it.
Yeah, totally. I think to your point there, Belinda, it definitely needs to be looked at in the clinical trial, right? What data we have so far is retrospective evaluation of prospective collections that suggests that it is a prognostic biomarker. If it is detected, patients have inferior survival compared to patients who do not have it detected. However, we still do not have data on how predictive it is in terms of if I have a positive ctDNA and to use a therapy sooner, can that lead to prolonged survival? Can that lead? So making a change in the management, we still don't know. So we need to definitely look at it in the clinical trial further to help answer that question. But regarding the clinical trials that we do, Dr. Akshay has, good number of investigator-initiated trials, like who he leads, along with our team together. We try to incorporate ctDNA as part of a correlative biomarker, like something that we like to follow along. The first focus is going to be to make sure the study is completed, vetted out, well done, make sure we have the results out from the primary study. But at the same time, once the results are out, then go back and look at the lab level, answer the question about do the responses from these drugs that we're adding on, is that correlating at the molecular level in the blood with this circulating tumor DNA testing? So thankfully, we have a lot more companies out there that are offering this, but really an important tool to incorporate.
One more question we get a lot is, how often should you get the biomarker testing then, the genomic testing then? Yeah.
All right, I'll take this one. If you're talking about MRD or minimal residual disease detection, which is usually done with curative therapy, actually ctDNA testing is not really standard of care in biliary tract cancers and hepatobiliary cancers. I tend to use it, and I know my colleagues in the same clinic tend to use it, but not necessarily a standard of care, because right now, few companies would not charge patients for it. So I take advantage of it and see how it performs in biliary tract cancer patients. In terms of the molecular profile, either liquid or tissue-based, easier to really repeat liquid-based, but tissue-based could be a challenge. if you're asking about whether repeating the molecular testing will reveal other targets, I think it has a value, and sometimes it actually helps us to see if the target that disappears. For example, along the lines of HER2 therapy, if you treat with anti-HER2 agent first and then have a response and then it's disappeared or you have resistance, it actually could help you to see. In fact, you should recheck it to see if there is still a HER2 expression. Similarly, another example could be FGFR2 fusion. And one of the problems with the first or second generation drugs that are approved in that setting is acquired resistance to FGFR inhibition. You are targeting the mutation, but the cancer develops another mutation that renders your drug ineffective. And I have done it multiple times, and I was able to see the actual acquired mutation, which could possibly be overcome by another novel agent or a different drug that is designed maybe for that purposes. So, long story short, I think it has a lot of value depending on the case. I tend to repeat it if I think I'm going to be able to use the information for the patient. But if there's no use for that data and you need a new biopsy, it may not be worth it. And finally, some of the analysis of those samples could be from a few years ago, where another testing modality was utilized. For example, there are some fusions in the tumor that were not necessarily picked up by DNA-based technologies that were more common to be used a few years ago. Now we have NGS techniques that would pick up those fusions, and those fusions, like there's a fusion called NRG1 fusion, it needs to have an RNA-based testing done, highly effective drug. Not approved for cholangiocarcinoma yet, but for pancreas and lung cancer it is approved. So those are very rare fusions, but if you find one, you might actually change the trajectory of the case entirely. So it has a lot of value to repeat the test. Yes.
Any questions? All right, thank you so much. Well, that's a wrap, right? That comes to a conclusion. And I think this really want to thank everybody for the support and those who hang out all day. You know, it's a Friday, you have much better things to do. Really encourage the support here, which goes way way beyond, right? So to the entire foundation, first, I think to our incredible speakers. I think they have delivered such a thoughtful and insightful talks starting from the morning all day. I think that just brought clarity to these important topics like hope grounded in science. Then to the Cholangiocarcinoma Foundation team, I think this event wouldn't have been successful if I don't thank the entire team, Emma, Karen, Stacy, Elizabeth, Melinda. I think behind the scenes, we were meeting almost twice a month. When it gets closer, like almost once a week, to just make sure the agenda is right, like our event is organized the right way. I think that's phenomenal. I think I really loved the place as well overall. And most importantly, to our patients and caregivers, thank you for being here. Thank you for staying with till the end. Thank you for the support. And I was also impressed how actively you're participating throughout. So that means a lot. And finally, grateful to my two patients who gave the talk. So this to me is a dream come true. 3 years ago, thought of this dream to have CC appear. Maybe my next dream is going to be get them more often. Right. But as you continue your journey in the country, probably we could make a next time more shift as well here. But together, let's continue to fight cholangiocarcinoma. Thanks so much, everybody.